Board of Directors of Oxley's NHS Foundation Trust. We should have some guests with us today from our staff networks. So we should have Juliana, Craig, Laura, Kelly and Kay. We should have an observer from NHSE East of England with Javid Patel, and our governors, Sue Hardy, Sue Sauter, Les Clark and Tina Strack. So a big welcome to you all. We have some apologies for absence. I've heard from Amlan Basu and Joe Stimpson. Sally, do we have any other apologies? Sally? I can't hear of any other apologies. In addition to our governors, we have Richard Diamond, and I think Richard, our lead governor, this is your last board meeting as lead governor. Just want to thank you so much on behalf of Oxley's for the role that you've played over some considerable years now, both as a governor and as lead governor, and skillfully combining that role with your local authority role as a councillor, and being extremely careful to differentiate between those roles. And I've particularly enjoyed our discussions, and you've been a great source of advice as well. So, Richard, thank you ever so much for what you've done, and you'll be very welcome back at any time to come and listen in to our discussion. So many thanks on behalf of the board. I have one or two technical problems in this part of the world. So to save me dropping in and out of that, I'm going to hand over to Stephen Dilworth, our Deputy Chair, to take us through the rest of the meeting. Over to you, Stephen.
Thank you, Andy. And just checking in before we start, are there any declarations of conflicts of interest? I can't see anybody raising any. Thank you very much. Let's go to the minutes of the last board meeting held on the 1st of July. So first of all, for accuracy, page 1, page 2, page 3, page 4, page 5. Azra?
Apologies, I was slow with my hand there. It was on page 3. And it was under the, I'm trying to identify the paragraph. It was my comment, and it was in regards to digital inclusion. So could we change the word escalated to accelerated, please?
Yep.
Thank you.
I'm sure that's okay with everybody. Thank you, Azra. Nothing else on that page, Azra, from you? No? No. Okay. Page 4. Page 5, page 6, page 7, page 8. I should add as well that outside of the meeting, this is mainly for observers' information, but non-executives will have fed back to Susan Owen any comments we had both on page 1 and part 1 and part 2 of the minutes, so they would have already been incorporated. I'll take those minutes as approved. Everyone in agreement? Thank you very much. Any matters arising from those minutes which aren't dealt with already in the subsequent copious board papers? I'm sure everything is dealt with in the 580 pages. Right, not seeing any comments there. On to the board assurance framework. Sue Owen and no doubt with comments from IFE as appropriate, but over to you, Sue.
So for this meeting, it is just to note the board assurance framework. There are 2 new risks added on cybersecurity and on carbon zero, which I think are the main things for the board to note today. We've reduced the risk on ligature management to a low risk in light of the work that's been done to mitigate that. And we've given in the front sheet some examples of the additional assurances we're collecting around that. and work continues to refresh all the other risks on the board assurance framework. And in November, I believe the plan is to have a fuller discussion of all the BAF risks.
Thank you, Sue. And you're absolutely right. Yes, we have been saying for a while we were going to have a more comprehensive discussion. And as Sue says, we will be doing that at the next meeting. I'm also just going to quickly come to Steve James, if I may. Steve, you, and I know Suzanne's got her hand raised. I'm just going to go to Steve first. Steve, you were sharing with us previously about some thoughts about how the BAF may be related when we're having meetings to our risk appetite. Do you want to just share that with us?
Yeah, thanks. It's part of the piece of work that Andy's asked me to do about governance, and I was one of the people I talked to pointed me to a couple of trusts who relate their risk appetite to their BAF, or how they discuss their BAF, so that as long as the risk appetite and the BAF risk are the same, they don't get talked about all the time, but those boards talk about when the risk appetite is out of sync with the risk in the BAF. So they will talk about it when the BAF risk exceeds the appetite, and when it doesn't, because if it doesn't exceed the appetite, or if it's below the appetite, why is it on the BAF? And that's how they filter the discussion. So they review the BAF every 6 months, but every meeting looks at the BAF in relation to the risk appetite, which seemed to me to be quite a good way of managing to cover all the bases, because I've been trying to think about how we use the BAF, because it's very good, how we use it more often. So I think that will probably be part of the recommendations when I write it all up. But it did seem to me a useful way of combining the two.
Yeah. Sue, any thoughts on that? I thought it was a very good idea. Yeah.
Yeah, I've seen similar examples of how other trusts have brought risk appetite more visibly into the BAF. So I think it would certainly be useful to explore how we do that, so the risk appetite doesn't sit there as a standalone document. Thank
you, Steve. Thank you. Thank you, Sue. Suzanne.
Thank you, Steve. I just wanted to comment on 3 of the risks. The first one is the ligature management risk, which I think needs updating, because the reasons for keeping this on the BAF are not really reflected, I think, in the way in which that risk has been described. And indeed, most of the mitigation actions have been taken. There is an additional mitigation which I think is should be on the BAF, which is the plan that the estates team has developed to proactively update all of our kind of environmental ligature provision over the next 3 years. So I think it'd be helpful if that BAF risk were slightly rejigged if it's going to stay on the register. The other things I just wanted to comment on were the 2 BAF risks which we've raised from the Infrastructure Committee. I'll say something about net zero carbon when we get to the report of the committee. But again, I think that the cybersecurity risk, we did have a discussion at the committee which slightly altered the way in which the cybersecurity risk was originally described, to take into account what we might describe as the human factors in generating cybersecurity risk. So I think that one probably needs to just be tweaked a little and to remain on the BAF, but with that additional element included.
Thanks for those thoughts, Suzanne. And Sue, perhaps you could touch base with Rachel T on the ligature aspect, and with Alison on the cyber security, just to amend those slightly. Thank you for that. Just a couple of thoughts from me. Azra, I'd be interested in your comments just about the ICS 1984, which is a famous date, of course, which we've got noted as moderate at the time being. What your thoughts are on that, whether that's the right grading. And just an observation, 1213 vacancies and recruitment pressures. I know it's rated as high, which is probably where it is, but I rather suspect we will be revisiting that over time, because I think it will be a growing risk. But Azra, just your thoughts on, have we got it right as a grading? Is it high enough on the ICS financial risk?
So I think we did look at this quite carefully when we were judging. So I think on H1, absolutely, the risk there would actually be low. But what we don't have is the planning cycle yet for the H2 planning, which is the October to March. And that's the reason it's actually hit moderate. Now, I do in reality think that we will be able to mitigate most of that. Revenue, I'm not worried about. It is the capital element that I am worried about. So that's the key driver for why that is moderate rather than low. Revenue, I genuinely think we will not have an issue with. Capital, the risk that we've got there is we are very overstretched on our 21-22 capital. We have other partner organisations in the ICS that have got significant pressures and significant capital programmes that they have committed to and indeed started internally, where we have not yet received capital cover for. So it's not included within our capital envelope. And the risk here is effectively saying, will we be asked by the ICS at some later date to cut back on our existing agreed share of the ICS capital envelope in order to help to mitigate some of those issues going forward? Now, we're actively managing that within the trust to ensure that we're maintaining and will be able to fully utilise our capital envelope. But we are at the same time proactively looking to see, is there anything that we could slip into future years? I think for Oxleas, and this comes back to Suzanne's point on the ligature risks, which is the reason that's really still on the register, is whereabouts will some of our safety issues fall when we've got other organisations in the ICS that have got leaking roofs or they've got some really major medical equipment issues. And that, I think, is the big reason that that risk is sitting as it is, because it covers both revenue and capital. Capital is definitely our key risk area there. I do think it's moderate for this year because I think we've got a plan going through. When we reassess that next year, that may end up high, and that will come out of the 22-23 capital programme and the mechanism that we're going to use to do that. And we are discussing that very proactively in the infrastructure committee.
Thank you. And just to manage our expectations, and I agree with you, 22-23, particularly on the capital, is the big issue. Do you think we will end up, or we're likely to end up with different risks for ICS revenue and ICS capital?
We may at some future date, I think, want to separate those out, because I think there is, I'm saying that, I'm worried about what the 22-23 revenue position will be for the ICS. But because we haven't had any of the guidance on that, so they may both be equally risky in future years, is what I am saying. For this year, I'd group them together, but I think it's, and we have got it detailed within the actual BAF risk. We've differentiated, and I've said revenue low, capital is definitely the higher risk. If the board think it would be better to have them as two separate risks, we could do that in future years. I'd suggest keeping them together for this year, though.
Absolutely. Thank you, Azra. Iffy.
So I think it's a good question you raised there, Stephen, as to whether we need to separate. Yes, I accept that we don't know what's going to happen in 22-23, but some of the initial discussions at the SCS executive is that we may be looking at a potential reduction of 4 to 6%. Of our income across the ICS, and I'm not sure what that might mean for Oxleas in particular. The deficits are looking more like 560 million, as you know, Azra. So 22-23, everyone thinks will be harsher for obvious reasons. We spent a lot of money this year and last year on account of COVID. So we may get to a point where we need to separate, so there'll be the opportunity to write a bit more about why we're rating capital one way and revenue another way. Right? And I think that would be clearer for everyone to see and should help discussions.
Thank you, Effie. Okay, have I any more questions? In terms of the agenda for this item, we do say to accept the BAF and consider whether the framework continues to provide sufficient assurance. So in a way, I'm taking no further questions, and thanks for the points raised by Suzanne, Iffy and Azra there. I'm taking it that we're happy to move on from this. And of course, as Sue said earlier, there will be a more detailed and fuller review at the next board meeting, and also possibility of ad hoc meetings for NEDs in between that time. I see no further questions. Thank you. I will move on to item 5, Chief Executive reports, Iffy, and of course, as per all the reports today, we'll take it as read that they've already been perused, but I'm sure you will point us towards the key points for us to consider.
That's a really good pointer, Chair, given your comment about the copious papers. And I do apologize on behalf of the exec. You will have noticed we've got 6 annual reports, and when we have these reports, they're really quite large. You know, it just so happened that they've all come to the same board. But we'll try our absolute best to take you through. So just 2 or 3 things to say on my paper, which, as the Chair has said, I'll assume colleagues have read, and then I have 3 or 4 further things that are not on the paper that I just need to touch on. So just from the point of view of noting, we know Matthew has left, and I warmly welcome both Abby and Tom as joint acting medical directors to the board. COVID is still upon us, and all we're doing within the organization is maintaining infection prevention and control measures as directed by Ian Gold of the ICC, and also requiring our staff to complete lateral flow tests twice weekly. I think Ian will probably touch on vaccine uptake. We think it's much better than what I have in the report. You got to remember my report was a week ago, and so we're constantly writing to individuals to ensure that they take the second vaccination, and those who haven't taken any vaccination at all, we're encouraging them to do so. I just want to draw attention to the really useful evaluation report from London, which is mentioned in my paper with a link to it. And I'm really hopeful that we're going to draw on this as we continue the process of top-up vaccines and also vaccination of other groups. And a really positive story to mention, which is the fact that the Mayor of Greenwich gave us an award, which was received by Helen, our service director in Greenwich. Just some other things to pick up on. 4 things, like I said, the South East London ICS, as colleagues will recall when we last had our NED update, the board and the partnership membership has been agreed, and they go live in shadow form from November. There are, however, a number of appointments that remain outstanding, not least the Chief Executive Officer position, and some of the other executive positions like Medical Director, Director of Nursing, Chief of Staff, along with the place leads, and also confirming who would lead the respective provider collaboratives. I anticipate that all of these appointments should be made and should be completed certainly by next month, given that we're going to shadow in November with a plan to go live in April on the back of a successful law coming through for the NHS in terms of how we do this. COVID vaccination, you may have heard in the news yesterday that the JCVI have now advised who should receive the booster vaccination. I think there are roughly about 500,000 immunocompromised people who will get this first. We're still awaiting further advice as to what happens to others. The 12 to 15-year-old vaccinations, as you also know, is very much a topical issue. The JCVI has again prioritized a number of children who are immunocompromised to get that. And then we're coming into the flu vaccination season. And so there's a lot of conversation about how we do all of this, both in terms of whether people should get both the flu vaccine and COVID vaccine at the same time. There are potential challenges, not least the fact that with flu vaccine, You went in, you got it, you walked out. With the COVID vaccine, particularly if it's Pfizer, or indeed any of the others, you're likely to have to wait around for 15 minutes, and that has implications for staffing, size of building, etc. So there are lots of other things to walk through. We think that in Southeast London, we'll need to at least aim for 80,000 vaccinations each week. We also need to consider the sites for such vaccinations. If it's, like I said, Pfizer, we need to ensure that you've got the prerequisite refrigerator for temperature control, etc. The sites may well come down. And there was conversation at a meeting a few days ago about special groups, particularly pregnant women, in terms of how do they get their flu vaccine and COVID, should it be an antenatal, etc. And of course, all the issues about young children continues in terms of who gives it, how do you get consent, is it paper, is it electronic? And the reason I say all of this is that if you imagine the scale of the task, that if it's on paper, it's going to be slower as opposed to if it's done electronically. The other thing I wanted to touch on, everyone would certainly have seen on the news the terrible plight of Afghanistan people and the number of refugees being taken by different parts of the West. We've got 700 refugees in quarantine at the Intercontinental Hotel in Greenwich, and we are having to support them along with our partners. We think that by the end of this week, certainly by Monday, some of them would have been through their quarantine, and the next step will then be determining where they go. I'm reliably informed that Greenwich has agreed to host 20 families in Greenwich, which they think may mean up to 100 people because of family sizes. I'm told that there's a 17-year-old unaccompanied who has already been made a Greenwich resident from the point of view of safeguarding. There's been a lot of activity, much of it unknown to many of us, ambulance transfers for those who become acutely ill, clinics being run to ensure that those with long-term conditions are supported. And SLAM and Oxleas have, in the last week or so, been preparing to support people in mental health crisis. And on Friday, we sent out an email across the trust asking for volunteers to help with the distribution of clothes that people had donated, because the hotel clearly couldn't have allowed people to walk into a room and just pick up clothes as they choose. And the final point, the final thing I want to mention, I would never have thought that I'll be saying this to a board, that across England we are short of blood specimen collection bottles, but we are, and we've all been asked to reduce blood tests by 25%. And I know that Abby, Tom, Jane and colleagues have met to think about what this might mean for us in Oxleas in terms of reducing the frequency of laboratory investigations that we conduct on our patients when they come into hospital, or indeed in the community on account of any health conditions. And so those were all the things I wanted to talk about. I'll stop and happy to take questions.
Thank you, Effie. And also apologies, of course, I should have said welcome to you in your first meeting for some time as Interim Chief Executive. And thank you very much.
Thank you.
Thank you very much for that very concise report. If I can just throw a couple of questions to you, or first of all, an observation on the ICS situation. I think where we are that we've seen a lot of guidelines, but I think you'll agree in the run up to legislation next year, there will probably be a whole flow of updates as various negotiations take place. Thanks also for the update on the Afghanistan and the support of refugees. That's been very good to know. Two questions. First of all, what's the fascinating about the blood tests? Do we have a time frame when that will no longer be applicable? We're talking about months. And the second thing I wanted to just ask, Thanks for the about the vaccination rates for staff at 80%, and I know we're continuing to raise that. Are you concerned about that rate? Are we happy about having got to 80%, or do you think we should still be aiming for a much higher rate for first doses? So vaccination rates and the impact of the blood tests.
Yes. So the blood tests, what they think is that this will probably remain a problem for 3 or 4 weeks at the outside. Likely to get worse, but we should see the back of it no later than the end of September. But we'll see. Obviously, we need to kind of do our absolute best to reduce unnecessary blood testing, which I know does happen, frankly. If a GP has done a blood test in the last 3 months and someone comes into hospital, you don't need to do it again unless there is good clinical reason. It's about reaching out to grab hold of the last result. Now, the vaccination, I can see Ian wants to come in. I'll tell you what my view is. I think 80% is good. I think it's probably higher than 80%. We were talking about this yesterday, and we haven't quite got the seat rep yet. And I don't see any harm at all in us continuing to push, if possible, to get to 100%. We may not get there. I think nationally, I think it's fair to say that we're in line with what the figures are across England. But I would personally love us to see 90-95%, even if 100% cannot be reached. I'll make room for Ian and Jane. I think.
Yeah. Thank you, Ife.
Yeah.
Over to Ian.
Yeah, thank you, Chair. I mean, in terms of the latest sit rep, in terms of frontline staff, putting aside 9% are exempt, and Jane may want to say more about what the criteria is for exemption. We're currently at 86% for our first dose and 72% for our second dose. So we've closed the gap a little bit since last week, but clearly there's a bit more work to do from my point of view, particularly closing the gap between the first and second dose. But Jane, I know, would like to say more.
Thank you, Ian, and good to hear that news. Over to you, Jane.
Thank you. I was just going to reinforce the gap really of people who are still undecided to have the vaccine is only 5%, and we're very keen to continue to understand from some of these people how we could support them, and we'd be very happy to listen to their thoughts or reassure them if we can in any way. And we know it takes time for people to make a big decision like this, so the vaccine is going to be available for some time, and we continue to support people to have it. In terms of the exemptions, there are very limited reasons why somebody can't have the vaccination. It's within the Green Book, and the main reason is a previous reaction to a component of vaccines called PEG. But other people's clinical specialist consultants will know their individual cases and will be able to make proportionate risk-based advice discussions with them, and that's what we're basing the exemption on. Everybody's risk assessed and everybody's able to make an informed choice based on that. The challenge that we really have though is the changes to the care homes, and from the 11th of November no NHS staff will be able to go into a care home unless they're double vaccinated. So that means people must have their first vaccination by the 16th of September at the latest to have the second one 8 weeks later. And we've done an extensive piece of work to reconcile and understand what the risks are to care homes, so every team knows that they've got enough people who are double vaccinated and are managing that situation. And part of the review of that has helped us to identify more people who have actually had their double jabs now, and that data has come in. So we're regularly pulling off lists and reviewing that to keep up to date. And also part of that, we had a number of people who previously declined who have now confirmed that they've had the vaccination. So every week we get a little bit closer to closing that 5% gap. I really need to thank everybody for the hard work they've put into that. Thank you.
Thank you, Jane, and I echo your thoughts in terms of thanking the people who've been contributing to that. Yemisi.
Thank you, Chair. I just wanted to confirm that the percentage between the first and the second dose, that's because people aren't due for their second dose yet. and just to confirm whether we had a problem with getting people back for their second dose. And if we did, are we sending out the right type of communication as to just how important your second dose is, because your level of protection from the first dose really does diminish if you don't have the second one.
Any comments on that?
We've got some data on a few staff who have declined to have their second doses for various reasons. So we know who they are, and they are, obviously encouraged to access it, and the information is provided to them. But generally, most people are having their second doses. I think it's about 72% of the data that we know of, and a lot of it is we just don't know, rather than they haven't had it at the moment.
Thank you, Jane. Ian, yes, you were going to say something, but presumably Jane's covered that. Thank you. Do I have any more questions? I'm not seeing any more. So thank you very much, Iffy, for that report. If we can now move on to Ian for the operational update. And again, I realise, Ian, this is very comprehensive and detailed, 40 pages. So if you could just concentrate on what you feel are the key points for us to note.
Of course, thank you for that steer, Chair. So I'll break this into 3 parts. I'll briefly go back to COVID, although a lot of what I was going to say has already been covered. I then wanted to just highlight a couple of the key metrics on the IBR, and then thirdly, I'll just highlight a couple of things from the operational report. But as you say, Steve, it's fairly comprehensive and hopefully self-explanatory. So in terms of COVID, we've talked about the vaccination rates. In terms of how COVID is being experienced by our inpatients and our staff, currently we have 0 inpatients who have a positive COVID diagnosis. And within prisons, it's a handful of prisoners at the moment. And in terms of our staff, we have 4 staff currently with a positive COVID diagnosis, and 28 staff in total off with a COVID-related absence. So I think there's reason to be kind of relatively optimistic from that data. Just a couple of other things around COVID, just to let board members know that the PPE hub that was based here at Pinewood has now moved to Queen Mary's Hospital. We're anticipating that the PPE hub will continue to operate for the rest of this financial year. Expecting to continue to receive push deliveries centrally around PPE until that point. The care home kind of subject, which Jane has already mentioned, that is something that is obviously preoccupying quite a few of our directorates at the moment, because most, if not all, of our directorates to some extent will have patients they're working with within care homes. So part of, as Jane has said, part of the work to understand vaccination rates within the organisation has been to try and mitigate any kind of problems that might arise when the new rules come into effect on the 11th of November. And then the last point, which again Iffy has already mentioned, is the fact that there will be a programme of vaccination for 12 to 15-year-olds. Colleagues from Children and Young People's Directorate are engaged in conversations at a regional level around what the ask might be of their services in delivering that programme. At the moment, it's still in discussion, but I think there's a fairly good chance that there will be a requirement for colleagues from the Directorate to participate in that programme. So we'll just have to keep that under review in terms of what that means for capacity in terms of delivering other bits of work at the same time. So if I just move on then to the IPR, there were 3 metrics, and this has been discussed at length within PQAC, that have proved quite stubborn in terms of an improvement. So I just wanted to give the board an update on where we are with those. The first is metric 10359, and this is around prisons, and it's about having a care plan set up within 2 weeks of assessment. I think I have probably said before that this has been impacted by COVID restrictions and therefore access to prisoners. However, I'm pleased to say that this has started to improve. And for July, the performance across all prisons, bar one, has improved on the performance in Q1, with half of the 10 prisons now operating at 100% against that metric, and the remaining 5 between 50 and 60%, but with an improving trajectory. So I think it won't be long before we will be back to where we were previously. The second one was B22, which was the CPA 6-month review. This is still subject to some variation between the directorates, as you'll have seen from the pack. However, Bexley, Greenwich and Forensic Services are operating at or just below the 95% target for the last 2 months. So I think we are nearly there. Bromley and CYP remain outliers with more variation, I think, in performance. In Bromley, it's between 85 and 90%, so not far behind over the last 3 months. And CYP, there has been a slight deterioration since April, and they're currently operating at 84%. But I've been having conversations with the CYP directorate in the last few days. And there does seem to be an issue around the accurate recording of appointments as CPA reviews. So I think the true figure in CYP is probably much closer to 95%. So that is something that I'll continue to look at and certainly report back through PQAC. And the work to get us to the 95% is what I've described previously, which is around making sure that the scheduling of the appointments is maintained, correct data entry, and also moving to include this as a part of the monthly CPA audits. And then the last metric I just wanted to highlight was 11520, which was the 72-hour follow-up for people who self-harm. Again, this remains subject to fluctuation across the 3 boroughs. Having said that, both Bromley and Greenwich have achieved 100% in the last 3 months. Just to reiterate what we have done to try and get us back to where we need to be, we have reviewed and adjusted the flowchart with the directorate, so it's much clearer what the expectations are over different people within the system. Importantly, each senior management team is receiving an exception report where the follow-up didn't take place within 72 hours, so that an understanding and a mitigation of any risk that arises from that takes place. And we're still working on getting that aggregated up to the trust exec for review. But it is something that all of the directorates are very much focused on. The final metric that I just wanted to highlight was around inpatient rosters. I'm sure colleagues will have seen from the report that we are not where we need to be. Again, something that has been subject to variation over time. And this is really going to need a big push. And I think it is around selling the kind of benefits to both staff and to the organisation of getting these things sorted out early. Colleagues will remember from previous conversations that I think in terms of helping staff to plan their lives around work, this is a really, really important thing to get right. So I will have, I'm continuing to have further conversations with both the directors, but also with Rachel, and see how we can do something different around this. It may be something that we want to consider as a QI project in the future. So that was the IPR, and then just to highlight a couple of things from the Directorate operational reports. The first was around procurements. I just wanted to highlight a kind of very positive development again within CYP, which is that the Integrated Therapies Service in Greenwich won't be subject to a re-procurement, which was something that was being talked about at one point when the contract ends in April 2022. Instead, commissioners have indicated that they want to work with us in a collaborative way to redesign the pathway without the need for procurement. And then in forensic and prisons, we have heard, it's not in the report, but we've heard in the last few days that the pharmacy contract in Kent has now been extended to 2023, which I am seeing as a kind of positive thing for us and the way that we're perceived by commissioners. We still have not received any word on the Kent prisons procurement. I did contact Lawrence yesterday, and the latest is that we have been promised a letter next week. But frankly, we have been in this situation at various times over the last month, but hopefully this time we will. And the other thing I just wanted to just mention in terms of forensic and prisons, the Wandsworth recovery plan, which I talked a bit about at the last board and subsequent PQAC, that continues to be implemented and is indeed being reviewed through PQAC. I'm pleased to be able to say that we have not experienced any further deaths in custody since the last board meeting, and as well as the recovery plan, I am co-chairing a board level inquiry into the 3 most recent deaths in custody at Wandsworth, and that will be reported on at the November board. And finally, and I promise this is the final thing, just to highlight that within the operational report across all directorates, I think they are highlighting a number of challenges in relation to weights and the work that is being undertaken to address these. This continues to be a major focus of our post-COVID recovery, and it is obviously something that links in with the zero delays work, which we'll hear more about in a moment from Lorraine. But just to highlight that this is a major focus of all directorates and will continue to be for some time. And indeed, this was reinforced for me, I think, on the news this morning, NHS providers really kind of highlighting the challenges that are around in terms of weights. And for a trust like us, it's important that our challenges aren't obscured by those of the acute. Obviously, the acute have a big backlog in terms of kind of elective operations, but we have our own kind of version of that elective recovery. So I will leave it there. Thank you very much.
Thank you, Ian, and thank you for that focus on the report. Ian, no hands up at the moment, so just if I may kick off with some questions. In the IPR, the Integrated Performance Report, and particularly on the caring section, so there are a number of items there where we seem to have a long-term issue in not meeting the targets. Would you like to just comment on that in a general sense? I realise COVID may be at play here, but are you optimistic of sort of getting back nearer to the target ratings?
Yeah, thanks, Steve. I mean, I think you're right. COVID, I don't want to overstate kind of the impact of COVID, but I think it is a factor here. Just as you know, in terms of kind of direct delivery to patients, a lot of that went online, and we're kind of resetting that following feedback from patients. I think that, you know, caring and working with carers has been impacted by COVID, but I feel confident that we will get back to where we were previously. And it's not just an operational focus, of course. It's something about our kind of strategic approach here. and something that I don't know, Neil may want to kind of add to, but I think we will get back to where we need to be.
Okay, thank you. One more question, then I'll go to Steve James, followed by Yemisi. You mentioned page 44 in the bundle about the discussions with Bromley, section 31, and you touch on significant or this may have significant implications for integrated practice in Bromley. Are you able to expand on that slightly? Because on the face of it, that sounds quite a strong warning to us.
Yeah, I mean, I'm kind of aware that I might be overstating the risk of that. I mean, I think any review of our kind of joint arrangements with local authorities may end up in a situation where we enter into a divorce from social care. So I think that the kind of worst risk would be for us is that those arrangements are disentangled and social care staff that are part of our integrated mental health offer are pulled back centrally within the local authority. I mean, I'm not sensing that is something that is that the local authority in Bromley are looking for, but I guess given that the current section 31 has lapsed, it's in the process of review. That is a possibility. But I think the strong relationships that we enjoy with the council and Lorraine as service director has really cultivated those over the last few years, put us in good stead. So I think it's a risk, but I think it's a risk that we shouldn't be too concerned about.
Thank you. Steve James, then Yemisi.
Thank you. My question really was a follow-up about the caring bits on the table, because I get the comments on the website and our responses to them, because I was interested in them in the past, and so communication send them to me. To what extent do we triangulate the stuff that comes through patient experience and others with those comments? Now, it will be fair to say that some of those comments are extremely positive, but the majority of them are extraordinarily negative. And they're on the website, they're publicly available. And I know they're relatively small numbers, but how much notice do we take of them, and how much do we triangulate those with other things that we know about patient experience and what people think of us? Because as I say, they describe particular instances that appear anyway to be dreadful. So I just wondered how we treated those.
Sure, thanks.
Neil is best placed to answer, because it's also in the annual report that we'll come to later, I think.
Yes, so we've just recently PALs and complaints have taken over the responding to the website. So previously that was with communications, so we are looking at it very carefully. There is a process. I think when we see those responses, we then ask the local teams to look at that and to try and identify who the person is. And there's often a kind of context behind what people have written. And I think that's really, really important, because we get feedback on that. So we do pick it up. I think we don't take it at face value. We try and find out what the story is underneath. And then we ask for a response from the local team. But it's linked in with complaints and with PALs, and I'll come to some of that in my report. But I agree. I think a great deal of those comments are about access, and that is about sort of accessing treatment and about people feeling that they're left to wait. So we're keeping an eye on that trend, because that's slightly different from some of the trends through complaints, although it's very similar to some of the issues that happen through PALs, where, so it seems to me a better home for kind of thinking about those decisions and how we respond.
Okay, thank you, Neil. Steve, I'm not sure if you wanted to come back on that, or...
Not particularly. I always struggle with they're relatively small numbers, but they could be really important. You know, there might be a canary somewhere telling you things that the data doesn't tell you. I just think we need to be really, you know, careful about that, because statistically they're not particularly significant, but they might be telling us something that we're not picking up in other places.
Thank you. That point I'm sure will be noted by Neil. Yemisi.
Thanks, Chair. Ian, I just wanted to pick up on the waiting lists, and especially those waiting lists that have developed since COVID. And we can see that it's a challenge across many of our directorates. You know, for example, MSK, because they were shut, now have over 2,500 people on their list. Are you confident that the mitigations that we have in place are robust enough in order to reduce them? And what kind of timescale do you think we need in order to get them back to pre-COVID levels? I think I just wanted an indication as to how big the scale of this problem is and for what length of time we should be thinking of dealing with this.
So thanks, Yemisi. I mean, in terms of putting a kind of concrete figure on the length of time it's going to take, I would be reluctant to do that. But this isn't going to be something that we're going to sort out overnight. Just the kind of sheer number, as you've indicated, for a service like MSK is huge. So I'm confident with the way that the people currently waiting are being managed and how we're prioritising meeting their needs. But obviously that doesn't mean that everybody's going to be seen quickly. We have had access to kind of short-term funding to try and reduce waiting lists. Of course, that creates a new issue about are the people out there to recruit, but I think we've had some successes around that. In terms of community health, particularly, I think we haven't seen the funding settlement that we had hoped, and that has a big impact on our ability to kind of sort this out more quickly. So that is a very kind of concrete limiting factor. And there are a lot of asks for that funding when eventually does arrive. But I think the funding I think we've talked about previously, there was a big gap in the funding that we wanted this year and what we actually received. And the messages we're getting is that funding will become available, but it's going to be staggered over a number of years. So I don't know that this is something that is going to be resolved by the end of this financial year even. I think it's going to stretch beyond that.
Thank you, Ian. Suzanne?
Thank you, Chair. I just wanted to seek Ian's reflections on the data that we've had on remote consultations. And the reason I'm slightly worried about this is that we have a strategic commitment to deliver remotely where appropriate. But if I look at the data, there's a kind of ineluctable downward trend away from remote delivery towards face-to-face. And that may be because our patients prefer face-to-face meetings, but I'm wondering whether it's partly because our clinicians prefer face-to-face meetings. And I just wonder if you've got any reflections to share with us about that.
Yes, I do, and I'm sure others would as well. I mean, for mental health services, I have been very clear that I think COVID necessitated us to put a lot of our service delivery on a kind of virtual footing, whether it was video conferencing or telephone. And I think that has had a negative impact on an awfully large number of our service user group. Not everybody, but a large number. And I think we've talked previously about how that might be linked to an increase in crisis presentations, an increase in the number of people being detained in hospital. So I've been actually, I think I've sent out kind of clear messages that I wanted to see more or certainly in the kind of mental health sphere, of those contacts being brought back face to face. Abby has put some very helpful kind of guidelines out to community mental health services about how they might approach it. And I think it's a conversation that we will need to keep revisiting, Suzanne. So I'm not sure we're quite there yet in terms of a kind of optimum level of virtual against face-to-face, but personally I'm not concerned that there has been an increase in the number of face-to-face contacts. I think community physical health, it's a slightly different scenario anyway. So much of that is about putting, crudely, it's about laying hands on patients. And I think it's appropriate that a majority of that work is done face-to-face. But again, it's about, are there opportunities to that we can spot, and now from experience that we can use to enhance what we do using technology. I think IAPT has been a very good example of where it seems to have worked really well. So I think it's about judicial, being quite judicious in terms of how we use it, and weaving that into the kind of agile working conversation.
Thanks, Ian.
I have a note from Azra. Was that something you wanted to introduce into this meeting, or?
It was just really for background around the MSK weights. So it's not, in all of these cases, we've explored a number of different ways of trying to mitigate the waiting times. We started off with agency and 12-month fixed-term contracts. In certain areas, that's just not been successful in being able to attract anybody into the roles. So for those areas that we think we can permanently over-recruit, and we've got a good grip of the turnover rates, and we've modelled that, we've actually approved, certainly for MSK, an over-recruitment of permanent staff, which we think we should be able to recurrently mitigate over 18 months, which will help to address some of those areas. We're proactively looking at that across a range of areas where we've got challenging wait times. So it was just to introduce the fact that we were working on it in the background, and we're not just looking at agency, but it wasn't intended to prolong the conversation, more for background for the board.
Thank you, Ezra. I appreciate that. That's very useful intervention, actually. Steve, is that an old hand or a new question?
Sorry, it's an old one.
Okay, no worries. Ian, just as a bridge to the waiting list situation, on page 73, there's a reference to client cancellations increasing by 55%, which obviously must have an enormous impact on our productivity and the number of clients we can see in a day. I'm just wondering, are we making sufficient resource perhaps of volunteers in this regard who could perhaps be ringing up patients on the day just to check they're available for, to make sure they're going to attend the appointment, because, we know the problems that causes if they don't attend. I don't know if this touches on the telephone befriending project or whether that's totally separate, but it's really, is there something more we can be doing about the 55% increase in cancellations?
Yeah, no, I think they're both really good ideas, actually, Steve. I mean, we do have various reminder mechanisms that we employ across different teams using text, etc. But I think what you're perhaps pointing to is that there may be some worth in kind of real-time human engagement in terms of, and that might have a bigger impact. So I think that's certainly something to consider. I mean, again, not wishing to overstate the kind of COVID context, that did impact on patient confidence in kind of coming to appointments. But I would hope that would be starting to kind of recede as the world opens up. But I will certainly take those kind of points you've made and discuss further with service directors.
Thank you, Ian. I don't see any other hands up at the moment, so I'll throw in one more question. Page 51, you refer to SEL, a clinical steering group being set up. which I think for myself and many of the Neds often makes us a bit twitchy, as if this is means a delay in a necessary amendment to service provision. So this is for on the IAPT. Do you have any feel for how quickly that steering group will be reporting some meaningful recommendations?
Yeah, so that I mean, that's an interesting conversation around IAP. So this has come out of the fact that across South East London, there is quite a lot of variation in terms of outcomes that services are achieving with different kind of resources. And I think there, when the conversation first started, there was a view that appeared to be coming forward from the ICS that there was a model that in one of the inner London boroughs that perhaps was the one that we should all be adopting. Choosing my words here carefully. But I think what myself and other Oxleas colleagues kind of put forward was that it's about the kind of context for that borough that needs to be looked at. So I think what that has meant, and I think this is, so what I'm getting to is I think this process is actually quite useful because it is around really exploring all the issues before we kind of finally settle on a way forward. And I think that's probably quite a good thing for us and the service we provide in Greenwich.
Thank you, Ian. I appreciate that update. And I can't see any more questions, so I will move on. Thank you very much again. On to Oxley's strategy, item 7. Is this Lorraine or someone else?
Yeah, I think that's me. Thank you, Chair. And I've been made aware of the task ahead of you in terms of the number of papers. And so my intention is to assume that you've read the paper that's in the bundle. I'll do a brief summary and then give people the opportunity to ask some questions, if that's okay. So I think in terms of zero delays, people will be familiar with the case for change by now. Put very simply, we want to provide the right care at the right time without any delays, and we know that that will provide better experience and outcomes for patients, but also we know that staff satisfaction really increases when they're delivering good care at the right time. So we've provided some of the anticipated outcomes. It's been a busy couple of months for this programme of work, and we've been looking at the work in 3 fairly distinct areas. So there is a significant and emerging need for us to have some focus on informatics support. So what we know at the moment is that our teams have got a pretty good grip on their waits. They can tell you with some detail about who's waiting in their teams and for how long, but we don't have a single system or a technological solution that enables us to view that at a kind of a senior exec level. There's also been a programme of work that actually started in CAMS ahead of the Zero Delays programme, but fits very nicely in terms of the work that we've been doing, and that's provided a good opportunity for us to learn both in terms of technology and service support. And then we've been doing some targeted support sprints with a number of teams, and these have been really exciting. Staff have been really engaged in this work and have actually responded really positively. So 5 service areas have been targeted so far. They're listed in the pack, and they've gone through a process of diagnosing what some of their delays might be attributable to, planning for how they might kind of do things differently, and then an implementation phase. And within the pack, you can see for the Greenwich Early Years Speech and Language team, just a diagrammatical representation of that work that's happened. But this is certainly the work that has really kind of motivated our staff around zero delays and created some energy. So in terms of kind of where we're going from here, obviously we have got that learning from the CAMS work, we know that for them it's taken quite a considerable amount of time to get to where they've got to, but that's for a number of reasons around mostly complexity. But we want to take that now for the rest of the organisation and start to map the as-is pathways for all of the teams across the organisation, and then begin to do our redesign work. We know that there'll have to be some prioritisation within that. People may be aware that there is a new weighting standard coming into play for community mental health teams, which we anticipate formal reporting will start in 2023, but some shadow reporting will start next year. And that requires any referral to a community mental health team to have had a contact with an intervention within 4 weeks, which is quite a change. And certainly when we've been in some of the London-wide kind of meetings, I think like most other providers, that is, represents quite a challenge. And so it felt important to focus on community mental health because we've got to do that anyway, and we didn't want to disrupt any plans that we might have had with work that was then introduced on top. So the focus will be on community mental health. So in terms of those immediate next steps, we've got our first steering group on the 21st of September, which will be a good opportunity for the first time bring together all of the work that's happening across the organisation around zero delays. We're going to have some further conversations with informatics colleagues around what the technological solution might be to some of this, and come up with some timeframes and plans, and also develop our methodology for how this is going to be rolled out across all the teams. But I think it's important to say, whilst we're doing that, the sprints that we've been doing and the work that's been really engaging teams will continue. And we're having a focus which started last week and will continue next week on the service user sort of co-production consultation element of this work. So we've had 2 meetings with a group of patients so far, and that's been, really interesting. I suppose unsurprisingly, they've been very candid about the impact of delays, but also very understanding of the fact that they need to wait. So this in no way is suggesting that patients will get a service the minute a referral is made. They've been incredibly understanding about the fact that there will always be a wait. So one of the things that we want to do in terms of our first piece of co-production is the letter that goes out from our services to patients that explains what their potential waiting time is and what they can do whilst waiting, is an important kind of first step in that messaging, which they've described as being probably the most important thing that we can do at that point of referral. And so that's going to be certainly a focus for us over the coming weeks. I think I'll stop there if that's okay, and just take any questions that people have.
Lorraine, one quick question from me. Just to manage our expectations, when do you think some meaningful data will come out to show us the progress on the various strategies, and particularly the one about zero delays? So meaningful data, did I say that? Yeah.
I think I suppose we're looking at this sort of in terms of the entire organisation, but of course we're doing it chunks at a time. So if you look at, say, CAMS as an example of the first service area that will have some data, we've probably already got some, and that can certainly be built on in the kind of coming weeks. And then I think it will be kind of incremental data based on those sprints that we're doing. So we can certainly put together, I think, some interesting kind of data around conversations that we've had and work that we've done with teams around demand and capacity, for example. And that could certainly form part of the next update. I think we do already have some. and I think it will grow. But in terms of an organisation wide, I think for us it's really been about looking at how we chunk this work up so that the expectation isn't that we wait until we can do the whole organisation in some big bang approach, which isn't going to be terribly helpful and could, disrupt other work. This is about kind of, those priority services and being able to give you a kind of sense of what's changed and what's different and what the data tells you about those teams. But getting a baseline is really important, and I think it was really tempting to rush off and start all sorts of interventions with teams, because you could see that there was opportunities to kind of do things differently and to really kind of make those positive changes. But we have had to make sure that we've taken a bit of a breath and got that baseline data, because I guess that's what will give you your evidence that this has worked. If we start kind of doing too many things at once, then you don't know what's made the positive difference, and you haven't necessarily got that baseline to be able to say, wow, look what a difference this has made. So we've it's been perhaps felt a little bit slow, but I'd say it's just been cautious, and actually the work that we've done on those sprints has been incredibly positive and engaging, and staff have really bought into that.
Thank you, Lorraine. I've got Iffy, followed by Suzanne, then Steve. Iffy?
Thank you, Chair. Mine isn't really a question, just a comment. So thanks, Lorraine. Thanks to Morehouse colleagues. I'm really excited about this work. I'm particularly excited by this sprint. That is QI in action, right? So this is about getting our staff who deliver care and engaging services, as Lorraine talked about co-production, in thinking about how can we do this better. And so whilst we know where we want to get to, I think the process in itself is really, really quite positive. There's a balance to be struck, isn't there, between do we just rush and say, oh, we've got to deliver this by 6 months or in a year, or do we do it properly so that as teams are thinking through this work and working with Alison's team, informatics, etc., we're actually addressing and transforming services, because I think it would be a real shame if we said, oh, it's got to be zero delays without engaging the clinicians and users of services and families where appropriate to then come out at the end and still not have achieved what we need to achieve. So I think that regular feedback to various committees, the exec and the board, and being able to clarify to the board what's different from the last time we came here. So Lorraine has kind of painted a picture, but I'm really excited by that graph in the sprint. And when we talked about this at the exec, there was quite a lot of discussion. And so when we next come back, it will be about, right, what have we achieved, what's different, and we'll keep doing that. I'm really pleased that Rachel Claire has us on the leash. She's got this is about the strategy. She's very clear about who needs to come next and what needs to be brought here. So that's really great. Thanks again, Lauren.
Thank you, Effie. And as you say, regular updates would be much appreciated. Suzanne?
Thank you, Chair, and thank you, Lorraine, for a really interesting report. I found it, there's a lot in here to get on top of and to appreciate about what you're doing. I just had a few concerns or anxieties, and I'd appreciate a response to some of these. The first one, and this might just be to do with the way in which the report is, the sort of drift of the report, but as I read through it, I found myself thinking, has the strategic aim of zero delays morphed into a strategic aim of reduced wait times? And I recognise that those two are related, because the more we can reduce delays along the pathway, the more likely we are to reduce wait times. But there did seem to be a bit of a concentration on the reduced waiting times in this. And as I understood our strategic aim, it was very much to reduce delays within the pathway and not just getting into our care. So that was the first thing. The second thing, I'm really glad that you mentioned about the co-production, because the other thing that struck me as I read this was that there wasn't much evidence of co-production. And I think that what you've said to us is that that evidence isn't there yet, but it will be coming. And I really want to urge that co-production, in particular with patients and our service users, really is embedded as this work goes forward, because it's very easy to lose sight of. And you know, the sort of sense is that doing stuff with patients always slows things down. So when we're in a hurry, we can just, you know, put that bit on one side and get on with the work. So that was my sort of second slight concern. The third thing was about the extent to which we might get thrown off track by the introduction of these new targets. And I was thinking about, so what's the unintended consequence of saying the target is that you've got to have had a contact and first intervention within 4 weeks? And it seems to me that the unintended consequence of that is that you work really hard to meet that 4-week target, and then someone waits for another 6 months before they get to the second intervention. So I'm just wondering whether dealing with the unintended consequences of those new targets is part of the thinking on this. And then my final point, it was just about the measures, is that they're divided into qualitative and quantitative. I don't mean to be nitpicking, but when I looked at those, I thought, no, they're all quantitative measures. And that kind of reinforced my slight concern, actually, about the extent to which there was co-production actually embedded in this. So I'm sorry, that's kind of 4 separate points, but you know, I kind of hope that you might want to sort of comment on each of those, and you know, I've been interested to hear your response.
Thanks, Suzanne. I think in terms of the issue of reduced waits versus zero delays, it has been tricky. I think it's been tricky having those conversations with teams and staff and really helping people to think about this as zero delays rather than waits, which I think was almost a shock for some staff when we first started engaging, because I think they thought that perhaps we were suggesting that people were never going to have to wait for our services, which of course is never going to be possible. So I think we have got the message out there about delays, but I think possibly the reason at the moment at this stage it looks a little bit like there's a focus on waits is because in order for us to determine where the delays exist, we have to understand what a reasonable wait time is for each of our service lines. And for some of them that's really clear because we've got national guidance such as referral to treatment times, for IAPT or for EIP, etc. They've got kind of very specific targets, but for other services that's much less clear, and they've been locally kind of agreed, and that's been a bit problematic for us to unpick in terms of whether they're reasonable or not. So that's been a kind of an initial piece of work, and that's been quite helpful when we've done the sprints to really kind of think and kind of bottom that out. So hopefully as kind of things progress, you will see more clearly the kind of focus on those delays and not on waits. Co-production, I agree, is critical. I think it has to be meaningful. And for it to be meaningful, we just needed to kind of understand what we were doing a little bit. And I think we're there now. And I think the early conversations that we've had with patient groups have helped us to kind of think about where they can best help us and how we can include them in a really meaningful way. So again, I think that is something that you will see more of as the programme kind of progresses. You know, I think you're right to highlight the extent to which we might get thrown off by targets. It feels like a bit of a kind of seed change, but I think it's important that becomes the baseline for those services, because I think if we now construct a programme where we're going by our existing waiting time standards, then we're just creating kind of additional work for ourselves and a bit of an industry and constantly going over things. So I think by using that as the benchmark for those services is the right thing to do. And I think then it's just about me and together with, you know, colleagues ensuring that actually that becomes a helpful part of how we develop the programme for community mental health services rather than a kind of distraction. And the qualitative and the quantitative point, I'll go back and relook at those, and I think there's probably more that we can do to kind of make those clearer. I suspect we just need to add some different things to the qualitative outcomes to provide a bit more assurance around that.
Thanks very much, Lorraine. I found those really helpful responses, and I appreciate you taking them one by one. Thank you.
Because I can lip read, I know that it was my go. You were on mute.
I had to do it at some time.
Oh, yeah, I'll put my hand down as well this time. It's Lorraine, I thought it was really interesting, and it's lovely to see the weather so nice in Orpington, by the way. There was one sort of thing about presentation, because when I first read it, I thought that's a shame that physical health has not got the priority that it might have. Now, you've explained why that might be because of the things that are going to happen in mental health. It's just, if I read that and I worked in the physical health bits of Oxleas, I'd think, oh, it's, you know, our turn's not for a while. And I just think it might be worth making clearer why that is. You know, because, you know, Yemisi pointed out the MSK weights, which are going to, they're going to be lots of waits and lots of delays in that. And there are different sorts of delays. So I just think it's worth, because we do tend to prioritise as a trust mental health staff, or at least it appears like we do. It was just a small point, but if you read it, it looks like we're doing that again. And I was intrigued because I do think there's a point around reduced transfers between services. So is part of this work looking at teams? And have we got too many teams? It's one of the points that Matthew made a lot, was we have lots of small teams, and the moving of patients between teams always leads to delays, and often is the point where we make mistakes. So I mean, I think his point was fewer transfers between teams would be a good idea. I know that's phase 2, but is that something that's in scope for this piece of work?
Yeah, so certainly when we're looking at the pathway, it includes any handoffs that we have from, you know, one, it's not even teams often, it's parts of a team. So there's all sorts of points on a patient journey where people are waiting, and therefore there is the potential for them to be delayed. And all of that is in scope. And I think if you know, I sort of think back to things like the community mental health redesign that we did in 2015, and one of the kind of aspects that we looked at very closely of that was to try and reduce those kind of trade-offs between teams. And it's worked for some parts of the system, but it hasn't for others. And we have created a number of new places where people kind of sit and wait within a team. So that's definitely all in scope. And I think, just back to your point of adult community health services, we were very conscious of that. And actually, we did an options appraisal of how to prioritise the teams. And one of the options was to focus on adult community health for precisely the reason that you've described. And I think because of work that's going on, particularly in kind of COVID recovery with community health and just some other kind of South East London initiatives, with the kind of support of that directorate, we chose to do the community mental health because of that national standard. Although one of the community neuro rehab teams has been part of one of the sprints and actually have found it incredibly useful. So when we're doing those sprints, we will continue to ensure that there is a focus on other parts of the organisation outside of mental health.
Thank you, Lorraine. That's Iffy, you were touching the screen there as if you were going to ask a question, but maybe not. No, you weren't. Okay, thank you, Lorraine. That was very comprehensive answers. No more questions. And thank you for also using Carlton Parade as a backdrop, which I don't think we've had before. On a sunny day, as Steve has mentioned. Okay, over to Jane now to do building block 3, creating a safety and learning culture.
Thank you. I'll take a leaf out of Lorraine's book and just do a really brief summary for you. I'm really excited by this building block. I think if we can get this right, it's going to make a really big difference to our patients, their families and our staff. A cultural shift is always a really interesting phenomenon to try to steer, but we've had really good engagement, particularly from lead clinicians, and we're continuing those conversations. So I think this is ambitious, but I am absolutely in no doubt we're going to achieve it over the next few years. So there's a national case for change as we are required to implement the NHS patient safety strategy, and this focuses on the foundations of a patient safety culture and safety systems. And for Oxleas, we especially want to create a culture where people feel comfortable to talk about patient safety problems and how to resolve them, how to innovate, and not have any fears of reprisals or punishments or a blame culture, which we all currently hear about across the NHS. And for us, this is really building on embedding our values and making sure that everybody is living their values in the context of patient safety. So it's going to need everybody to be part of this and everybody to be leading on the implementation. We've broken the building block down into a number of primary areas to focus on, and these are the psychological safety and well-being, very much requiring, as I say, our values to be embedded. It's about keeping people safe. So we've identified the areas of focus, and we're using the quality management framework as a way of taking these through control planning, assurance and improvement. We want to focus on inclusivity, so we want to bring in some patient safety partners. Leadership and knowledge, this will be the rollout of the National Patient Safety Syllabus and the development of patient safety specialists. And learning, and this will focus on how we roll out the PSIRF, the Patient Safety Incident Response Framework and Plan. There are other elements of the NHS strategy that will be built into an action plan to make sure we deliver them, but for the purposes of implementing this building block, the areas I've just mentioned will be where we're really focusing. We've established some process timeframes and we'll be measuring these incrementally, but one of our key measures what we'd really like to see is getting us into that top quartile for feedback on safety culture within the staff surveys. And our next step is really to continue to engage our leaders and have the conversations about how we create psychological safety within teams as one of the key foundations for this. It does feel a bit nebulous, but hopefully the discussions that we've been having internally and externally and with experts in the field, we've managed to articulate something that we can work on that will be the building blocks within the building blocks. Thank you.
Thank you, Jane. Steve James.
Thanks, thanks, Jane. It was very comprehensive, and I think it obviously should be a priority that the trust has. I suppose my question is, it's about patient safety. So the measurement of success should be, are they safer than they used to be? And I think we need to be careful we don't drift into process measurement, not outcome measurement. So on the measuring success, all of those things, patient safety syllabus, numbers trained, patient safety partners, all that stuff is obviously a good thing to do, but it isn't an outcome. It's a halfway, or it's more than a halfway house. It's a stage before to keep people safe. Whereas the keeping patients safe list, that which is a bit before it, they seem to be the measures that we might want to concentrate on, not how many people are called champions, because that's a way to making people safe. It isn't a measurement of safety. So I'm always a bit nervous about I'm not a huge, I am a huge fan of embedded learning, but that's not really the point for me. It's did it change behaviour? And it's the same with this. That's the bit we need to worry about, not the interim bit.
You are absolutely right, and we will continue to measure all of the areas identified under keeping patients safe, and we look at those metrics monthly at the patient safety group. So in terms of going forward, we can report on some of those as well as outcome measures. I think that's a really helpful suggestion. Thank you.
I'll go to Iffy next. Suzanne, I know you came first, but I think Iffy probably wants to do a bridge on that last point.
I would quite have loved to hear Suzanne's point before going, but
okay, yeah.
Would that be okay?
Yeah, that's absolutely fine. Suzanne?
Thank you, and I share Steve's thoughts about what the outcome measures should be for this. I found this absolutely fascinating, Jane, and I know that there's been a huge amount of work going into this, and that taking the agenda forward with the PSERF and so on is it's a big agenda on top of the kind of work we're already doing. I wanted to take the opportunity to recognise that at the moment we're the only provider within our ICS that's rated good for safety, and I would quite like to see us rated outstanding for safety at the next CQC inspection. There's very few trusts have achieved that, but I think that we ought to be really ambitious here and be outstanding for safety, and it may be something that you would already feel able to reflect on about what we would need to do to get to that point. The other thing that I was, a couple of sort of concerns that I had about the, one was around the patient safety syllabus, and the other is around the patient safety partners. So I think the patient safety syllabus is a great collection of content, but if we were, for example, and I'm sure we wouldn't try to do this, if we were, for example, to try and deliver the patient safety syllabus with mandatory online learning, it would just be a complete disaster. That syllabus is only of any value if it sort of becomes embedded in people's ways of working. So I'm hoping that we will take forward as we start to implement our training around the syllabus, that we'll be using really constructive approaches such as simulation and experiential learning and so on, so that it starts to become something that people are excited about. And the other thing around the patient safety partners, my understanding is that NHS Improvement has left it very open to what your patient safety partners should do. And I don't know how close we are to having a really clear view of what we at Oxleas want our patient safety partners to do. The history of the NHS over the last couple of decades is one kind of littered with initiatives to engage patients in patient safety, which has just generated an enormous amount of frustration on the parts of patients because they feel they haven't been engaged in ways that enable them to make a genuine contribution. So I'd be interested in your reflections on that. And the last comment, and it's a suggestion here, and it relates to this issue about how we measure the outcomes. I agree with Steve, I think, about, for example, if we use the National Staff Survey, that does enable us to do some very basic benchmarking against other trusts, but they're sort of proxy measures, really. And I'm wondering, given that we have the scope with the staff survey to include additional questions, which are our selected questions, whether we might look to the next round of the staff survey to have some really good questions in there about the outcomes we're looking for in terms of patient safety.
Thank you, Suzanne. They were really helpful suggestions. In terms of the patient safety partners, we started doing this work a while ago. Obviously, it's been delayed by NHS England because of the pandemic. And at that point, we looked at the role description and had conversations with ResearchNet, and they were quite interested in helping to shape that role. But we've planned a discussion at the next strategic exec looking at the role of the patient safety specialist, so we can explore the role of the patient safety partners there as well. It's still open for development. I also share your plea to make sure that this isn't a tick box mandatory e-learning. This has to be kept live, and the only way people learn is if they get that emotional connection to it. So simulation and experiential learning and debriefing is all going to be really important. And that takes us back to everybody being engaged and the leadership, especially the clinical leadership around this, and how important that is. And yes, if there is a possibility for additional questions, the staff survey is a fantastic platform that we could utilise. And obviously we will be asking people regularly when we talk to them about whether they're seeing changes or feeling things are different within their teams, and trying to get some feedback as well without it being through formal routes.
Just to let you know, Jane and Suzanne, Rachel Clare has just added to the chat. Sadly, we have missed the boat for this year to add those questions to the National Staff Survey, but can definitely consider for 2022. Okay. Thank you, Jane. Thank you, Suzanne. Iffy?
Thanks, Chair. So grateful to both Steve and Suzanne for those helpful comments. You know, as Jen and I have talked and reflected on this, it's really quite difficult to know how you evidence change. But one of the things we all know through working in healthcare for a long time is that if the culture is right, patient safety will improve. You know, and it's not about what markers we use. It's just that people feel confident, feel safe to discuss their mistakes and to share with others, you know, and that's why it's a cultural shift. As I've sat here and just think about the NHS, there was a time where we were in the top for reporting incidents. So the NHS has always struggled to find a way of identifying trusts that have a good safety culture. It's the feedback from the staff who use services, the degree to which they are open in reporting when they've got it wrong, and then demonstrating that they're learning from it. It's about what patients say, and of course about incidents. But there's some incidents that are really, really difficult to use as marker of success or not. If you take suicide, for example, or homicide, you know, we certainly don't want to go there. And so we're going to constantly, as with most of these things that require cultural change, we're going to constantly find ways, diverse ways, and there may be process measures. I get that. But if the feel is right, you would know. I mean, everything I've read on this will say that if you find an organization with good safety culture, it just feels different. That's what people say, you know. And I hope that we will, in time, get to that point where, as Suzanne says, I quite like the challenge, actually, of being outstanding for safety. You know, I think we need to be bold and ambitious in Oxleas, and not just a safe organization, you know, in terms of just getting on with day-to-day stuff. You know, so that's perhaps something we should look for. How can we ensure that when the CQC or regulators visit us, that they come away feeling, oh, the culture is right and the evidence is here that, you know, we really are learning and trying to improve and do better by our patients. So again, as with most of these things in our strategy, got to watch this space, you know, and we'll keep coming back to you and hopefully keep refining on the basis of your feedback. That's very helpful.
Thank you, Effie. And certainly that will be an excellent ambition to have, I think, on the, as per Suzanne's suggestion, on to achieve an excellent grading. Thank you for those very comprehensive reports on the Oxley strategy. Jane, we're still with you on the Cirrus Incident report. By the way, just so people can manage things, I probably think it would be a good idea after this to have a short break. It'd be quite timely, but with you, Jane, on Cirrus Incident.
Thank you. Can I just start by saying, if anybody is watching this, it may contain some upsetting information, so please take 10 minutes out if you'd like to, if you're in the public domain. I'll invite Neil to comment on this as he chaired the report, but just to summarise, our patient BB had been admitted to Scadbury Ward in December following a suicidal ideation. Between the 15th of December and the 20th of December, he was on the ward, he was compliant with his medication, and there were no concerns. After the 21st of December, the ward staff felt that his mood was improving. He was taking part in occupational therapy sessions. He was eating and drinking. Yet by the 28th of January, he himself was reporting that he was feeling worse and he hadn't been making improvements. But the ward staff continued to observe that he was brighter or more interactive and gaining weight. Sadly, on that same day, he tested positive for COVID-19 and had to start isolation, which at the time was for 14 days. And it was later during that day, around 5:45, that he was sadly found with a ligature around his neck. And he had creatively constructed this by using a number of items collectively, so not using a particular ligature point in the room. Neil chaired a thorough investigation and came up with recommendations around reviewing the ligature management policy to include the combination of articles, putting in place to ensure that high-risk information or change to a care plan, including observation levels, is verbally shared with ward staff immediately, even during exceptional circumstances, and for us to consider providing training on baking of bad news, which will include holistic risk assessments and reflective practice, ongoing management of situations, and that we need to explore developing a harm to patient pathway so that our staff have clarity about communication needs following a serious incident. And I think it highlighted to us that in line with the NKISH reports nationally, that older people's demographics continue to evolve in respect of self-harm and suicide risk, and cognitive impairment is a more protective factor. Neil, I don't know whether you would like to add anything, any comments on that?
Thanks, Jane. I think you give a very, very good summary. It was very hard to extract general learning from this, given this happened at a peak period in the pandemic, when I think the ward was itself under huge pressure. There was an outbreak of COVID on the ward. Many staff were affected by COVID. The outbreak meant that every procedure took longer, so there was huge pressure on the staff, and very sadly for this individual, he received 3 very powerful forms of bad news on that day, and in essence we discovered a new risk that some people are able to, through if they have the skill, that they can tie together items to form a ligature risk, which we had not seen before. So very, very powerful specific things, but I think the learning that you've outlined, I think, are very useful about just trying to understand how we communicate when risk changes and how we liaise with families, and to support staff in having the skills to break those particular forms of bad news and then to risk assess afterwards. So that, I think, is generalizable, but I do want to just highlight how much pressure this ward was under when they were when this very sad event happened, and as a panel we were really struck by that.
Thank you, Neil. Thank you, Jane. Was there anything else you wanted to add? No. And certainly, I think in all the incidents that we've been involved with, you obviously a huge impact on the family, but also one recognises the huge impact on the ward and the staff involved. It's really is a very traumatic experience. Suzanne, followed by Yemisi.
So, Steve, I was on this panel, so I'm happy to defer to hear Yemisi's comments first, and then I'll come back. Okay, over to you, Yemisi.
Thanks, Chair. Mine was just a really quick comment, and it was based on the discussion we were having earlier when we were discussing the anti-ligature BAF risk and the suggestion that potentially we take it off the BAF. And in triangulation with this SI and others, we've obviously discovered that ligature played a role in it. So I think, I was just going to suggest that maybe, even though we have those mitigations in play, until we see actual outcomes from it, that it would be better if we left it on the back.
Yeah, sensible approach. Yeah, thank you, Yemisi. Suzanne.
Thank you. And as one of the panel members, I'd like to echo what's already been said about how sad a case this was. It was also the case of somebody who was an extremely intelligent and skilled person. And I think that we sometimes forget that our patients may be more clever and more skilled than we are. And which is not to excuse us in any way, but to recognise that as well as his sadness was a factor in this. I wanted to comment on a couple of things about the action plan and then the key learning. So the first thing on the action plan, I see that we've already explored whether or not an alternative mask could be used, which was part of the recommendation. That slightly misses one of the points that was made within the body of the report, which was that we recognised that the guidance which had been provided to staff around masking didn't include indications of how they should kind of manage the mask situation within the ward. And so one of the observations that we made was that this gentleman had a mask in his room. And so I think that one of the things that probably should follow from the action plan concluding that we can't use an alternative mask is that we need to offer some guidance to our staff about how to mitigate the risks to patients who do have to wear a mask when they're on an inpatient ward, and that it may be inappropriate for them, that they need to be taken away from them when they then go into their own room, because they don't need the mask when they're in their own room. The second point was about the key learning, and I know we've kind of differentiated the key learning from the action plan, but I think this really is an absolutely fundamental piece of key learning that came out of this case, which was that in the past we have seen older adults as having a lower suicide risk, and all of the evidence from us and nationally indicates that that is no longer the case. So my question is how that key learning is going to be disseminated and discussed, particularly among the professionals within the trust, because it's not part of the action plan. So I'm curious as to how that message is going to be got across or debated with those staff. And then the last comment I wanted to make was about the harmed patient pathway. I am absolutely delighted that we're going to approach this recommendation. There are two other trusts in the country that I know of that are seeking to introduce a harmed patient pathway. They are both acute trusts. I think we would be real field leaders to introduce a harmed patient pathway as a mental health trust at Oxleas. And I think that there are some quite complex issues to think about here, including when the harm, for example, comes from a homicide, which sort of raises issues which, for the most part, the acute trusts don't have to worry about. We have very complex deaths in our care. So I'm really excited about this, and I'm hoping it'll be one of those things that we'll be sharing with the CQC when they come to say, we've really kind of set out on something very innovative here.
Thank you, Suzanne. I mean, that's excellent to have that context on the harm patient pathway. I hadn't quite appreciated how significant that was. Thank you. Abby.
I wanted to respond to, thank you. I wanted to respond to Suzanne's question on how will we be able to disseminate the learning around the changing cohort of older adults. So that's something that has been recognised by staff working within those services themselves. So in the Older People's Care Forum, we have started drawing up what would be learning about the changing cohorts of older adults. I always use Mick Jagger as my example, that if Mick Jagger needed a service, he would be coming to older adult services. So we need to be thinking about the changing cohort of what is defined as older adults. So we are looking at that.
Thank you, Abby. First mention of Mick Jagger ever in an Oxleas conference. Over to you, Ian.
Yeah, I mean, I suppose I wanted to touch on a similar point. Not to prolong the conversation, but I suppose I think there is for me, there is still a discussion to be had about what this concept of an older people's mental health service is, because yeah, Mick Jagger is a very good example of the fact that people are a lot fitter, and what we term generally in society as an older person is changed over time, and that presumably links to the risk factors, etc. So I'm really pleased to hear that what Abby is saying, and I think it is a conversation that we need to keep alive, really, and keep going, and be quite flexible in our thinking in terms of how we design services in response to that change.
Thank you, Ian. Yes, I think that we'd all see there's some very good recommendations here about the shorter articles and the ligatures and the harm patient pathway, and the key learning at the end. So I think it's as ever a very sad case, but also some good recommendations to improve our practices and learnings coming out of it. So there is some positive aspect from that. Are there any more questions? I don't see any. Thank you. Okay, the time is now 12:19. Can I suggest then, as I mentioned before, we'd have a break because the next section is quite lengthy. So if we can reconvene at 12:30, I would suggest. It gives us 10 minutes and we can go on to item 9 with Jane. Thank you very much. Hopefully Jane is back with us. Are you there, Jane?
Yes, I am.
Excellent. So Jane, presumably we'll pause, as we go through these annual reports, we'll just pause briefly after each one. Is that the way we should do it?
It might be easiest if I present each one just with some highlights and then take any questions or feedback.
Thank you. And as you say, just focusing on the highlights and taking the reports as read would be great. So over to you on infection prevention and control.
Okay, thank you. I think all of these reports, the infection prevention, control, safeguarding and patient safety, are a testament to the teams that have been driving these over this year, particularly as this report's on the pandemic year. So I'd like to thank everybody involved. The IPC team have focused predominantly on the COVID pandemic and response, but have sustained their core activities of surveillance, monitoring and infection control. We've established the new work plan for 21-22, and again we will be looking at the compliance and making sure that the IPC board assurance framework is kept up to date and that we're meeting all national guidance. So in the pandemic, there was a real focus on interpreting and formulating national guidance into trust guidance, managing anxiety of staff and patients, and making sure that people had access to PPE, knew how to use it, were fit tested, and then we moved into the contact tracing and the root cause analysis for inpatient infections. It's been a very, very busy year in terms of the pandemic and IPC for obvious reasons. On a plus note, though, we've maintained a very low level of infection in relation to mandatory reportable alert organisms. So, with 0 cases of MRSA, MSSA and E. coli bloodstream infections in patients and community. And we just had 2 C. diff infections where post-infection reviews were done. Had low levels of outbreaks of diarrhea and vomiting, and the unannounced audit programme has gone well, identifying some really good areas of practice for management of waste, transport of specimens and vaccination storage. Training remained consistently high, over 80%, with additional training provided by the IPC team to teams as they need it. And the IPC team won the Corporate Team of the Year, largely due to their response to the pandemic. So I think it was great that they were recognised organisationally. I'll stop there and see if there's any infection control questions.
You're on mute, Steve.
Last time, thank you, Rachel. You referred to deep cleaning as part of the effective controls. How do we assess or analyse or be assured of the effectiveness of that?
The cleaning, the infection control nurses do joint inspections and audits for the cleanliness monitoring with the teams, and with I think it's ISS.
Thank you. Okay, Suzanne.
People may be aware, if they've read to the end of the bundle of material this week, that I did a board visit to the IPC team. That there are 2.5 of them, more or less, and I met with 2 of them. And I just wanted to voice what Ian has put into the chat, and which many people have endorsed. They did an incredible job during COVID, an unbelievable amount of work. For 2 people. I had no idea that they were doing a whole load of contact tracing of patients and staff in the early days. And my conversation with them really reminded me, that back in the early days of the pandemic, we didn't know anything. And so they were, seeking to prevent infection on the basis that at the time we hardly knew anything about what the infectious agent and modes of transmission and so on were. So I really, strongly endorse the comments which have been made in the chat, and also the fact that they were the team of the year. I think they did an incredible job.
Yeah, thank you, Suzanne. I would totally agree with you there. Any other questions on infection control? I'm not seeing any, so Jane, please keep going.
Thank you. I'll do safeguarding children next. Again, another team that have worked tirelessly throughout the pandemic. They have reported on the priorities and delivering against them during 2021, and also how they became involved in identifying themes coming from the impact of the pandemic on safeguarding and how we have been supporting families. We continue to endorse a think family approach to safeguarding, and we're taking steps towards integration of the strategic priorities and policy reflecting national and local children and safeguarding issues as a whole. So at the start of the pandemic and subsequent lockdowns, there was a rise in new safeguarding challenges. Our local trends pictured the national picture. We've seen increasing domestic abuse and risk of harm to young babies, deteriorating mental health of adults and young people, and a rise in online and exploitation risk, and concern for children who are unseen by professionals and those with disabilities. We've managed to maintain excellent compliance with training and education and meeting the needs of the intercollegiate document. An audit was carried out, the annual audit for safeguarding supervision, to explore and evaluate the experiences of supervision. And the results indicated an improvement from the 110 respondents and being able to access sessions, revised timetables, and they valued the remote online sessions. And 57% of them said that safeguarding supervision had changed their practice, increasing their confidence as well, which was good feedback. The immediate learning from a number of serious incidents is the importance of applying the think family approach to safeguarding. We continue to build on that. At the moment, the head of safeguarding is working with people to create a helpful video, and we're also having a champions event in October. So our vision for safeguarding remains unchanged. We continue to ensure that safeguarding and promoting the welfare of children is embedded across the directorate, and as I say, endorsing think family. And we will be working on our effective response to domestic abuse across all ages with our partners over the next year. We did identify during the pandemic a number of suspected non-accidental injuries, and a review was carried out of all of these. And one of the areas of concern was that the communication from the A&E departments with our health visiting services. We no longer provide the health visiting services, but we do know that the PRU have got a dedicated paediatric nurse in there. Accident and Emergency Department now, and the Queen Elizabeth has strengthened their safeguarding advisors. So our anecdotal feedback subsequently has been that this communication has improved, and we haven't seen the same level of suspected non-accidental injuries.
Thank you, Jane. You referred to the e-learning courses there, which seem to have been tremendously successful, as you say, with 3,400 nearly 3,500 completions. I'm assuming they'll be expanded to other sort of topics. I realise this is children's safeguarding, but I'm assuming things like eating disorder might also come into play here, and possibly PTSD. Again, I'm particularly thinking of perhaps refugee groups, but it certainly could be other groups. Any thoughts on that?
I don't think they're specifically referred to within the safeguarding children arrangements for training and development, but there's certainly access to training and development around those courses, of which safeguarding would be an element. So I think they're crossover, but they're not provided under the safeguarding banner.
Thank you. Yemisi, followed by Steve.
Thanks, Chair. Jane, it was just a really quick question about safeguarding and think family. We've obviously seemed to have done a lot of work in that area to join them up, but we're still seeing evidence of not the best practice in terms of safeguarding coming up in SIs and action points that relate to our improvement in safeguarding. Could you potentially highlight areas where we have particular challenges with achieving the Think Family strategy? Or do you think it's just a case of we are still quite early along this journey, so we still have a long way to go? Or what are your thoughts around it? Thanks.
I think the latter, in terms of the terminology. Think Family's relatively new. It was previously sort of contextual safeguarding, and now we're looking at multiple vulnerabilities. And we have a number of champions, several hundred champions, dotted across all of the services who are really taking this forward at a team level with the leadership of Ida Bradford as head of safeguarding. And we've recently introduced an IFOX monitoring form, which includes monitoring whether adults in mental health teams, particularly inpatients at the moment, have documented whether there's children in their network and if there are any safeguarding concerns. With this prompt in place, it is increasing the conversations and the recording of children and safeguarding. So I think, as well as raising awareness, we do need to give people the tools to do the job to make sure that they can evidence it. People still work in silos. We often find that, for example, inpatients sometimes don't liaise with children's services. Likewise, we've looked at IAPT recently. I think I am seeing a mixture of really good practice where we have case studies where it is really working well, and I submitted some of these to the Bromley Safeguarding Adult Children's Partnership yesterday. And then through some of our SIs, we're picking up that it's not as embedded and people don't feel as confident as in exploring what's going on with other family members, and we've got a way to go with that. So we'll keep going with it, but I think there are improvements being made every day.
Thank you, Jane. Steve James.
Thank you. Yemis has asked my question for me, to be honest, because I'm not convinced that the Think Family approach is embedded in the trust, not just from the SIs, but from staff's comments. And some of this should be as simple as I'm just surprised that one of the things that Oxley's staff don't do is to check whether another bit of Oxley's knows the family. Sometimes that happens, sometimes it doesn't. So it seems to me to be one of the sort of requirements when you take a referral, that you just check whether or not the trust knows the family. So I appreciate the prompt, but do people have to use it?
They should use it. And we've also created a new set of records around how to do analysis of who's in the family and do genograms. And it's these kinds of practices that the champions are taking forward with the teams at the moment. So we think talking about it, doing things about it, and showing that professional curiosity and looking at, who else is involved with Oxleas in the family is beginning to be a bit further along the line than when we were looking at some of the incidents over the last year. Certainly a huge amount of work has gone into it over the last few months.
Thank you, Jane. Sue Salter. Sue, I should have said at the outset, we normally take governor questions sort of in writing subsequently, but I know you've got a lot of experience in this area, so far away with your question.
Thanks, Steve. It's only following up from an email question, which I did say, and then thanks, Jane, for your response. But one of the issues I still had, and I don't know if you can help me out with that, because I appreciate Oxleas no longer have any responsibility for the health visiting service, and that I just wondered if that is causing any concerns in terms of referrals for NAIs in children, or even older children. Thanks, Jane.
Thank you. My team actually work in the multi-agency safeguarding hub. So we provide the safeguarding specialist advisors to Greenwich. So they will see all referrals coming in respect of any potential harms to children or families. And we had a few months ago, we did have an increase in referrals. We're monitoring these really closely, and the CCG are going to do a deep dive. But more recently, we'd seen them come down to the realistic levels. We haven't had any reports of particular changes following the services moving from Oxleas to Startwell, and also previously Bexley to Bromley. I have this week had one of the safeguarding advisors who left and went to Bromley, who has now come back to us, and she isn't reporting any specific concerns around increases in non-accidental injuries either, but we will monitor it closely.
Thank you, Jane. Thank you, Sue. Suzanne?
Thank you. I'm conscious of the comments which were made up at the front of the first of the two reports about the increase in perceived safeguarding risks following the pandemic, and also our capacity to respond with that rising rate. I know that it's incredibly difficult to benchmark safeguarding provision because everyone does it in a slightly different way. But when I counted up our number of whole-time equivalents, it did seem that we're probably at the lower end by comparison with other trusts. And I'm wondering what your thoughts are about whether we have sufficient resource to be able to attend to the post-pandemic risks.
That's a really good and helpful question, Suzanne. We have benchmarked ourselves and we are definitely on the lower end. We amalgamated our safeguarding adults and safeguarding children's team 18 months ago successfully, and that has increased capacity. We have a really good quality staff within the team. Doesn't necessarily make up for the quantity. During the pandemic, we were in extended business continuity with the safeguarding team, particularly the children, because the ability to deliver the service at the level that was required with long-term sickness, absence and vacancies was very, very difficult. ASRA kindly gave us investment for another year this year to have an additional member of staff to make sure that we could deal with some of the pandemic and post-pandemic demands. But we have also had the commission service, the MASH service was cut by 50%. So we lost a member of staff due to decommissioning of that over the last year as well. So things are incredibly tight. And I think it is a credit to the leadership and the calibre of staff that we've got in the team that they do so well. But it would not be effectively sustainable if we didn't have that calibre of leadership and experience in the team. And if we grew more gaps again for any reason, and staff do tend to move on to named nurse, designated nurse or specialist posts every couple of years, and they often come back again, but it would be tight.
Thank you, Suzanne. Thank you, Jane. And Ian has mentioned, by the way, in terms of IPC, what amazing work they've done. That's in the chat. No more questions at the moment, Jane, so back to you.
Okay, safeguarding adults. Again, safeguarding adults is two people who work really, really hard, Stacey and Andy, and we've managed to meet all our targets for safeguarding and prevent particularly. The key thing to note is we've seen a number of safeguarding adult reviews and domestic homicide reviews across all three boroughs. We're seeing an increasing number of these being commissioned, and they are very intensive in terms of independent management reports, presentations at panels involving both the corporate and the directorate services. So the key priorities that we've been focusing on and continue to focus on is around the use of the RIO safeguarding forms, particularly looking at this with the community teams. We continue to improve the accuracy of the data that we're collecting and sharing with the local authorities, thanks to iFox. We want to evaluate our learning offer. We're doing e-learning now for safeguarding adults, and we are working closely with the safeguarding adult boards in the three boroughs, all of which are very dynamic. In terms of the SARS escalation and the DHRs, we're going to have to find a way of coordinating these so that we can manage the workload and make sure that the learning is cascaded effectively. And I think the other really lovely thing that we've been doing over the past few years is the safeguarding superstars. So every month, Andy and Stacey identify an individual or a team who've made an outstanding safeguarding adults case and really made sure that what needed to be put in place was put in place. So we celebrate those and take those as good stories. and we share those with our partners for their annual reports as well. And we're going to be progressing the domestic abuse work stream. Recently, the domestic abuse bill has come out, and there's rather a lot of work that we're going to be doing to look at that.
Thank you, Jane. I'm not seeing any questions at the moment, so we'll go on to patient safety, which is page 224 of the bundle.
Thank you. I don't intend to go through the report because I know most of the things in it have been reported regularly through PQAC and the safety priorities, but I did just want to highlight a couple of areas. One is around resuscitation. A few years ago, we were very cognizant that people were not having a supportive experience when they were having to do CPR. And so we have made great progress with having Nick Stacey, our resus officer, in post, and she's really changed the climate. We're getting much more positive reports of actual CPR, how it's conducted, how people are feeling about it, and we're making really good improvements in people understanding what's in the resus bag and doing simulation in terms of drop the dummy exercises when we can, subject to pandemic. The other area I just wanted to highlight was the reducing restrictive practice. Again, we've reported on lots of the initiatives underway, but we are now extending the See, Think, Act framework, which has gone down really well in all areas, especially in the Bexley teams, the wards, Millbrook and Lesney, for example. And that's going to be entering phase 2 now. We're one of the 4 key players across London mental health settings for this work stream, and we'll be implementing a train-the-trainer model for this. We expect the safety pods to be delivered on the 13th of September. Training is being provided by Pomova, and the teams are looking forward to using them within their services, and we again expect this to make a positive impact on reducing prone restraints. So I'll stop there unless anybody's got any questions.
Thank you, Jane. And on the prone restraints, we can see that's going in the right direction. You know, presumably, again, just to manage expectations to ever achieve 0 will be immensely difficult. I think, see on one of the previous reports that you provided, one trust did, which did cause me some surprise, because I think, would you not say that there are always going to be some occasions where a prone restraint is probably going to be the realistic outcome?
I think we've got an absolute commitment to eliminating prone restraint wherever we can, and that message is really clearly heard by all of our teams. But there will be times when, you know, for clinical safety, that may be the option that the team are required to use. Yeah. And, you know, if it's appropriate, they will analyse what happened in the debrief and in a desktop review to see if there is anything that they can learn or that could have prevented that happening. But in the heat of the moment, it can be very difficult, and clinicians have to make decisions based on what's happening.
Thank you. That's a very, very useful comment. Suzanne?
It's just a quick comment about the trends in learning themes, which is summarised on page 232. And I always like a trend and a summary of the themes. But I think what I would really like to have seen here, because it appears on a different bit of the report, is what we've done in response to those trends in the learning themes. So I know, you know, so under learning from deaths, you said these are the trust actions in relation to learning from deaths. And I think it'd be really helpful with those learning themes to know what the trust actions have been in relation to those learning themes.
Yeah, thank you. That's a good thought, actually. So as you say, that's around page 232. Yeah, 232, 233. Yeah, thank you. Presumably, Jane, we could do something about that, yes?
Yes, of course. I think we've actually captured that in the mortality surveillance reports more recently. So yes, I can follow those up for you, Suzanne.
Thank you. Steve James?
Thanks. I guess I just wanted to note, really, just a sort of gentle challenge that we set ourselves 4 priorities and we missed 3 of them. And I think we do need to acknowledge that, because although there are reasons behind them, I mean, I still worry about the prone restraint, because I'm not sure the message has got through that basically we don't do it, and very occasionally there will be some reason why it happens, but organisationally, the culture of this organisation, it doesn't do that, and I'm not sure that message has got through. And so we just need to be careful as a board. I'm not saying we were doing, not just to go, oh well, we missed 3 out. We do need to note the fact that we set ourselves some targets and we missed 3 out of 4 of them. And there will be reasons, but we do need to make certain that when that the year that we're in now, that we do hit them. Otherwise, there's a danger of not taking as much notice of priorities. You know, the reason we set them was because we really wanted those things to be achieved, and we didn't do it. So we need to be careful that we acknowledge that, and then work hard to do it next year. Because I think that it's not glossing over it, but there's a danger that we sort of go, well, there we go, missed 3 out of 4, move on, and we should be careful not to do that, because if these are important priorities, then we really do need to put some effort into hitting them.
Thank you, Steve. Any comments from that, Jane?
No, I agree. An awful lot of hard work is going into this. The practice development nurses particularly are focusing on these, and we have made some changes over the last year. For example, on the news recording, we've really looked at why we weren't achieving it, and a lot of it is to do with the timing of the admission of the patient, and we shoot ourselves in the foot a bit really. If somebody's admitted at 1 in the morning, we're not going to wake them up 3 days later at 1 in the morning to do a set of observations. So we've extended the recording time and worked with some of the boards to see if we can take out patients that would be exempt. For example, they've gone for dialysis, so they're not there at the time, and then but they're legitimately being monitored, having their vital signs taken every hour while they're off the ward. So we just need to be a bit smarter about how we're collecting this data and not take it at face value so much.
Thank you, Jane. Steve, your hand's still showing, but I presume that's dealt with, yeah. And as has been said before, thank you so much for the various teams and the great work they've been doing in very, very difficult times. So that's item 9. Thank you very much. On to item 10, annual reports on patient experience and complaints. Neil.
Thanks, Stephen. So the report that you have in front of you details how we've been taking feedback across complaints, PALs, and patient experience. So we've worked really with 2 big measures, which are our must ask questions and the family and friend test. So just in terms of the picture over this last year, the NHS England did allow us to pause, but we chose not to. But there was a drop in the volume of feedback over COVID. In terms of the methods of the way that we get feedback, we've got 3 methods, and it's a very interesting picture how they performed as well. So we have paper methods, which is quite old school, paper methods, SMS and email, and using handheld devices like iPads. And actually, paper methods and devices tend to perform better than SMS and email. And I think the reason for that we're finding is that it's in the moment. It's your clinician actually handing you something, you fill it out there and then, whereas the sort of more remote surveys have disappointed in many ways because the moment is lost and people don't tend to fill out. So we're going to be looking much more at trying to encourage use of devices, because of course when we use paper methods that stacks up a lot of data input sort of problems later. The picture overall could be summarized really as we're below target in terms of positive ratings of experience, information about help received, and family involvement. We're above target in terms of making a plan, being treated with kindness and care, and communication needs. And interestingly, that does include where patients have been involved. So where, families have been involved. So they also rate these things highly when they have been involved. Obviously, they don't when we haven't involved them. In terms of families, we are now meeting our support network engagement target. This tool is a proxy measure of how we are mapping out and trying to understand who's important in the service user's life, who's in their context, how would they like to be contacted. So that's the first wave of our program to try and increase the way that we work with the people in people's lives. It's not always families, it's not always next of kin, but often it is, and that would include carers. So just going on to the complaints section. So complaints, compliments outperform complaints by about 4 to 1. Our complaints are about 0.03%, which is the same as the year before. We actually had something of a drop in complaints over the period, and a rise in the use of PALS service during the actual COVID period, which I think is a really interesting trend. Our reopened complaints are down from 18% last year to 6%, so people have come back less to have their complaints reopened because they're dissatisfied. The complaints themselves stubbornly stay with 3 main themes. Clinical care, so that's aspects of how the care has been delivered. It can often be quite practical things as well. But second is attitude and behaviour, and third is communication. The top 3 have been there for a number of years, and they remain the main areas of concern that come through in terms of the trends for complaints. Where we have struggled is to complete complaints in time within our own time target. So we have achieved 59% of completion within 45 days. We have had a 2-year QI project to look at how the systems have helped us perform in terms of getting complaints completed on time. It had some impact, but not much. So we're looking now to take a new approach to the whole complaints issue, particularly bearing in mind this very interesting trend that over the last year there's been a raise in PALS and a reduction in terms of complaints. So that's a sort of brief summary of the report. Just wondering if there were any questions.
Thank you, Neil. Neil, can I just, on a positive item, just ask about compliments? I see CYP did particularly well with compliments, and I just wonder, is that just the nature of the service for some reason, or is there something going on there that we could learn from?
That's an interesting question. So we tend to record less about, maybe we have a bit of a negative bias, we tend to look more in detail at complaints rather than compliments, but that's, yeah. So the short answer is I'd like to go back and see, but I think there's a lot more family involvement, so we can kind of triangulate it against in children and young people. And it may be that there's a feature going on there, because that's a big frustration within adult services. So we have a lot to learn from them. So no, it's an interesting one. I can go back and explore that.
Yeah, also Bexley Care seems to have done very well for some reason. So it'd be good to have any feedback on that. Thank you, Neil. Any questions? I'm not seeing any questions coming up at the moment. There you go. It's obviously self-explanatory, both what you said and what you reported. Thank you very much, Neil, and thank you for your team and what you do. Equality annual reports, item 11, Rachel Clare.
Thanks very much, Steve. So first of all, I want to give a really warm welcome to our wonderful staff network chairs who are here with us today. Now, not all of them can be here because of leave, but I know they all really wanted to be, and wanted them to be here really to recognise the really important work that they do and say a really big thank you, because over the last year, the work that they have done has been above and beyond, and I know they've really been there for people through very difficult times and been a fantastic support, often on top of really, really demanding day jobs. So a big thank you for that. We also wanted to give them the chance to pose us some questions as a board, and between them, they very kindly submitted 3 questions in advance. And what I'm proposing to do, Steve, if it's all right, is to go through the formal reports first and then go through the questions and our answers. Now, you might remember that in previous times when the networks have visited the board in person, feels like a very long time ago now, we used to also ask them questions as well. But what they've asked is that if you have questions for them, they really want to answer them, but they would really welcome a bit of time to be able to give them due consideration rather than trying to answer them on the spot in a formal kind of broadcast setting. So if you've got questions for them, do let me know. We'll put them in the chat, and we'll make sure that we discuss them at the next workforce committee and bring them back to you as a board in November. So we do want that dialogue flow to happen. In terms of the reports that you've got, so they are, you'll have read them, I know, and they cover two really important parts of our inclusion work, race and disability, but they don't cover all of those of the elements. They don't look at sexuality or gender or religion or age, but they do represent some really important work that we're doing within the Trust. And to put them in context, I think it's worth restating just how clear this board has been about its commitments to improving the lot of different groups in Oxleas. And some people have asked whether there'll be a change of direction with Matthew's departure. And I know that we would all say that the answer to that is a big, resounding, absolutely not. No change of direction. Building a fairer Oxleas is one of our central priorities in our new strategy. And I know for a fact that it's supported by every single member of this board. Just think it's worth making that very clear. So in terms of the reports themselves, the first is to give a bit of a health warning. So the data does involve relying on data that comes from our staff survey. Now, our staff survey data for that we have in this pack was completed by people in October of last year. So we have to publish now data which relates to October of last year. So it's just worth bearing in mind that some of the data in here relates to the position in Oxleas last year rather than now. The second is to say that we have used a red, amber, green approach to highlight our areas of concern. And I just want to say that amber is not a score or a trend that we're happy with. If a trend is amber, it's often telling us that there's been a really stubborn lack of progress and it's something that needs even more focus. And finally, I just wanted to say in terms of context that the report is obviously a backward-looking report, but what it needs to do is inform what we act on and what we prioritise for the coming year. So over the summer, we've had a big survey about building a fairer Oxleas and asking people what we should be focusing on for the second year. We've had lots of really good engagement with our networks, and what we will be taking to the next workforce committee is a set of interrelated action plans on the RARES, on the DARES and on building a fairer Oxleas that set out some really clear commitments for our second year. So in terms of the reports, I know you'll have read them, but I think there are just 3 points that I wanted to bring out. The first, and it's a low light rather than a highlight, is that we've not made the progress that we need on disciplinaries. What that means is that Black, Asian and minority ethnic staff continue to be much more likely to be subject to disciplinaries than white staff. We can point to the fact that our most challenging areas have the highest number of disciplinaries and that those same areas have higher proportions of Black, Asian, minority ethnic staff. And we can also point to the fact that this is a common issue across London, but neither are good enough explanations, and we need to do a lot more next year to fix this. We've had some really useful deep dive with the workforce NEDs, and we've gathered views from staff about what we need to do to fix it. And what we're going to do is we're going to directly tackle the spike in prisons that we saw last year. We're already making good progress. Lawrence Mack has been really supportive of this work. We want to make sure that our Just Culture panels are consistent in their approach. We want everybody who's on those panels to go through some excellent new training that Merseycare has deployed. And we want to join the NHSIE Vanguard scheme to make sure that we're adopting the very best cutting edge practice when it comes to how other trusts have approached this and where they've made the most progress. So that's probably my biggest priority coming out of all of this data, is fixing the position on disciplinaries for the coming year. The second point I want to bring out is about violence and aggression. I want to really give tribute to the fantastic work that a number of people, Chris Nakin, Christine Capopo and others, have done on the quality improvement projects that have led to a really fantastic 40% reduction in violence and aggression on many of our wards. And that bit of work, reducing violence, aggression and hate crime, is one of our building blocks of the strategy. And we've now got a really good group coming together on this, focusing on what we're going to be calling the 4 Ps: prediction, prevention, people, and prosecution and justice. There's a lot of work going on in this space, and we're going to bring it to the board very soon. The final point I wanted to make is about bullying and the perceptions of unfairness. And they continue to exist both in relation to disability and race at quite concerning levels. And I'll be honest, I think this is the one that's going to take the longest time to fix. I'd love to be able to give you a timescale for when these perceptions will change substantially, but I think that would be false comfort. People's perception in Oxleas about fairness and bullying have built up over a really long time. It's only 12 months ago that we were listening to really heartbreaking stories about persistent, inappropriate behaviours that have been going on for years in Oxleas. So specifically related to race, but we've heard similar stories about disability, LGBTQ+ staff and others too. And people are not going to forget those experiences overnight or even in a year. We know when people are completing the staff survey that these experiences are really close and really kind of front of mind. But what we can do, and what we have been doing, is to really listen to the people who've been experiencing this stuff and get them to tell us what would make the biggest difference. And for us to be really persistent and sustained and committed to maintaining our focus on the improvements for now and for the future. So we have been doing a lot. We've had a film about microaggressions, filmed by Oxley staff, about things that have been said in Oxleas, and it's had a real impact. It's not easy listening because we know it's things that are happening in Oxleas at the moment, but it is really starting a really good conversation. We've got a set of behaviours underpinning we're fair in our values. They make it really clear how we want people to behave and also what we want them not to do. And those are all created, all of those behaviours about fairness are all created from our detailed bullying and harassment workshops. So they're all built on feedback from staff. We need those behaviours to be embedded in everything, our leadership training, our appraisals, our recruitment, how we handle difficult conversations, what we do when we spot difficult behaviours, all of those. And then they really will be part of our culture. And the other thing we're trying to do is increase understanding. We've got going out to teams, talking to them about the video, getting a good dialogue going, and introducing a really impressive suite of new training on disability confidence, talking about race, inclusive leadership, tackling microaggressions, gaslighting, and much more. We've got a really good take-up. So I think it's right that I have focused on the concerning data in the reports, because I think we need to recognise there is a lot more we need to do. But I also think it's worth recognising that when we really do try and improve things, things do start to change. I think there is cause for some optimism, cautious optimism. So our Building a Fairer Oxleas survey over the summer showed that people are perceiving improvements to our culture. I want the progress to be quicker, but they are perceiving those changes. People are feeling more confident about talking about these areas of concern. We are seeing steady, sustained increases in the number of Black, Asian and minority ethnic colleagues reaching senior levels, with increases at every level. We're seeing good feedback about reasonable adjustments, and our board remains very positive in terms of representation. So whilst the data is not where I want it to be, and I do want it to be in a different place by next year, I do think we're going in the right direction, and I really want our commitment to building a fairer Oxleas not just to continue, but to intensify and grow. That's what I was going to say about the report. So I wonder maybe if we open up for questions here, and then I can answer the network's questions. Steve, does that sound all right?
That's excellent, and thank you, Rachel. And as you very rightly say, no change with Matthew's departure and Iffy coming in. You know, our focus on these matters, as you very rightly say, is exactly the same. Great to hear about the progress that is being made, but very good as well that you manage our expectations. Some things just won't change overnight. They will take time, particularly around perceptions. And also thanks to you and to the staff involved. And as you rightly say, who are doing their day job, but then in addition have taken on with their passion the challenge to further progress in some of these areas. So thanks to them for their involvement. Nina.
Thanks, Stephen. I just wanted to make a couple of observations, if I may. They're not questions as such. I think the reality is, as we at Workforce Committee and as part of the Building a Fairer Oxleas Action Group have uncovered over the last year, this is stuff that is deeply entrenched and it's complex, and it's been going on for a number of years. We haven't just ended up here. We're certainly by no means unique at Oxleas at suffering from some of these issues. It's contributory from management, from patients, from all aspects of society. So I think the fact that it's taking a while for us to turn the dial gives me comfort that we're actually going about it in the right way, because the original approach was to lift up the bonnet and really shine the light on what the individual component parts are. And those were difficult things to hear, but I think actually being able to articulate what the various aspects were has helped provide the route map for the work that Rachel has touched on and that her team is working really hard on. The thing that provides me assurance in addition is that at each and every workforce meeting, and we have meetings in between the bi-monthly committee meetings, we're getting into quite a lot of detail on and getting quite granular at the approach that we're taking. So I just wanted to provide assurance from a board perspective that we are I wouldn't want there to be concern that it's taking a while. I think that's actually the right answer. We may continue to see some ambers for a while, but it's because we're trying to go about, Rachel and her team are trying to go about things in a way that results in meaningful and sustainable change.
Thank you, Nina. Suzanne.
Thank you, Chair. It's a question actually, and it picks up on Nina's point about granularity, because every time I read the staff survey data, which lumps together harassment, bullying, and abuse, I think those are three really different things. And I'm wondering what we're doing to understand exactly what it is that people are experiencing in relation to bullying. You know, exactly what's going on in terms of abuse and what sort of harassment people are facing. You know, I'd share the comments which have already been made that these are not good data, and we really, you know, we need to start shifting the dial a bit. But I think that we can only do that if we really understand the phenomena that we're trying to change. And as I say, harassment, bullying and abuse are three very different phenomena. And within bullying, you have very different kinds of behaviours, you know, extending from kind of, you know, incivility at the less extreme end of the continuum to something which, you know, is tantamount to an assault at the other end of the spectrum. And you know, the data that we currently get from the staff survey doesn't give me any understanding of quite, you know, what it is that we're trying to deal with. And I'm wondering whether the Workforce Committee is able to disaggregate these data in a way that helps to understand the nature of what staff are experiencing.
Can I come back in, Steve?
Oh, yes.
Thanks. So, Suzanne, I think it's a really good point, and I think I often feel frustrated by the generality of the staff survey data, because so many things, as you say, are put into one bucket, and it's very difficult, I think, to see it as anything other than a flag that there is something here that needs digging into in more depth. I don't think in itself it gives us answers to any of these questions, although it is quite interesting to compare different directorate scores, for example, so that you can start to see where there might be particular hotspots when you triangulate that data with other sources as well. I must say that I rely more heavily on things like the really extensive stories that we have had submitted on an anonymised basis about people's direct experiences within Oxleas, the feedback at the bullying and harassment workshops about the sorts of things that needed to be encapsulated in our behavioural framework and that people think would make the biggest difference, as well as things like our microaggressions, which focus specifically on issues that were of concern to people in Oxleas right at the moment in terms of tackling those. And I feel that by bringing all of those things together, and to be honest, I don't think when people are ticking the box, they know whether or not what they're concerned about falls within the technical definition of bullying or harassment or whatever box it would be. So I'm not even sure that trying to drill down along those lines helps a huge amount either in terms of bringing insight. I think what we need to do is recognise that we're being given very clear messages about the behaviours that people are seeing that they don't want to be seeing and that are having a direct impact on their experience in Oxleas, and work out how we best do that. So there's some things around, for example, how we use our behavioural framework to have difficult conversations with people, how we use our behavioural framework when we're trying to manage performance, because often it's in those kind of areas that things get a little bit more tricky. So I think it's about getting in those pinch points, getting it right, and building on the data, on the information, the really rich stuff that we've already been told, and using that to drive it, I think, rather than seeing that the staff survey in itself is going to give us that insight.
Thank you, Rachel. Suzanne, did that answer your question?
It does, but it sort of prompted a further one. And I just wondered whether, Rachel, we've considered using any of the validated questionnaires on bullying, which some NHS trusts have used and developed, because they do allow people to identify very specific sorts of behaviours. And so it gives a clearer picture of what kind of phenomenon we're trying to eliminate. And, you know, it obviously kind of contains a range, but it's understanding that range that perhaps might allow us to tackle some of it.
Very happy to look into. I think that was the approach that was used for the bullying and harassment workshops that were happening just as I arrived, but I'll dig into that and find out. And if it's not something we've used before, I'll definitely consider using that in the future to try and get under the skin of it. Thanks for the suggestion. Thank you.
Yeah, thanks for that idea, Suzanne, and thanks for looking into it, Rachel. Excellent. No more questions. Thank you very much, Rachel. Anything else you wanted to add?
It's just that I had some questions through from the networks.
Oh, sorry. Yeah.
If that's all right. So there were 3 questions. One from our new women's network that was asking about the gender pay gap and how we want to follow up on that. Now, agenda for change generally means that females and males are paid the same pay band for the same roles in the NHS. So the basic position should be a bit fairer than in some organisations, but we do know that length of service impacts and that women are more likely to have career breaks. What we want to do is to really drill down into the data and look at the intersectionality piece a little bit more. What does it mean for Black women in the organisation? What does it mean for LGBTQ+ women within the organisation? So our commitment is, it takes quite a lot to unpack all of this data, but our commitment is that we will, over the next year, have a really good look at that and see what it tells us. The next question was from our disability network, who highlight that we know that there are some inconsistencies in the way that disabled staff are being treated during our recruitment processes. We know that I'm trying to make sure I use absolutely the right language here, but that our approach to the way that we make sure that disabled candidates are treated in line with our disability confidence scheme is absolutely right, and been really grateful to Craig for working with our recruitment team, for working out what it is that we need to do to make sure that our policy on guaranteed interviews is being applied in a consistent way, because we know at the moment that it isn't. So we've got a big programme of upskilling underway, e-learning guidance, brilliant disability confidence training for managers that we had a pilot of yesterday, which I think will make a really big difference for the organisation. So there is work we need to do to make sure that that guaranteed interview scheme is being applied consistently within Oxleas, but I'm really confident that we'll be able to make good strides on that very quickly. And then my final question is from Kelly, who's with us today from the Mental Health Staff Network. And that's a question about stigma. And what's the board's view on stigma, and how can we support the Mental Health Staff Network to address this subject within the trust? I do want to just take a moment on this one, because I know that the board is absolutely committed to tackling stigma. We know that prior to COVID, 1 in 4 people had experience of serious mental health issues, and that has gone through the roof since COVID, and that all employers, and Oxleas is no exception, need to provide really good support for our staff, particularly those who live with mental health issues. Personally, I think the NHS is a bit behind the game when it comes to mental health stigma. I think in other organisations over the last decade or so, there's been a real shift with senior leaders talking much more openly about their mental health issues and it being something that is talked about more openly. And I think that's less so in the NHS actually. And perhaps surprisingly, maybe not less so in trusts that provide mental health services. It was a bit of a shock to me, actually, how difficult people seem to find it to talk about their own mental health experiences in this sort of context. Something we want to improve for Oxleas because it's right for our staff, but also it makes such a difference to the quality of care that we provide. So we're doing a lot in this space. We want to support our managers to be better at those sorts of conversations. We've got this React 90 workshops that are really, really good. We want to continue to build on our excellent lived experience programme, really valuing the work that our LXPs do and supporting it to go from strength to strength. We want to create safe spaces for people, and our new mental health staff network and the new neurodiversity network are doing really good things in that place. And we've got lots of awareness workshops. But I think we can also start by us as a group modelling openness about mental health issues and using our leadership to start dismantling stigma. A very quick run through their 3 questions. I didn't want to take up too much time. I will continue to engage with the networks directly on these points, but if there's anything else that anybody wanted to add, then I'll open it up.
Thank you, Rachel. I'm just thinking of the best way to deal with this. So the networks in effect are looking for a response from the chair, and obviously we'll be guided by you on that. If they are expecting a written reply, would it be best for you to send something round to all of us and we would give you our thoughts in response to that rather than try and get into a dialogue? Is that okay for you? Would the networks be happy with that? Okay, so outside of the meeting, and we faithfully promise that we will respond very, very quickly to whatever timescale you decide, 24 hours or whatever. If you would like to send us out the questions and what you think are replies, and we will come back to you with our thoughts and any additional thoughts. Yeah, and I'm seeing nods of agreement, so I think all the Neds are happy with that approach. Thank you, and thank you for the network chairs again for all that they do. Thank you, Rachel. No more questions on that, so we now move on to risk management. Sue.
Yes, thank you, Chair. So the risk management report reflects our risk management activity over the past financial year. So a quick summary of the highlights. The number of risks on the board assurance framework did increase during the year from 11 to 17, and much of this was due to having a number of COVID specific risks which were added onto the BAF during the year, and by the end of the year they'd either been mitigated out or subsumed into existing risks. But we now are back up to, I think, about 16 risks on the board assurance framework. So we kind of are creeping up towards the maximum recommended number of risks. The 4 significant risks we had at year end remain the significant ones we have now around financial pressures and weights. The report also shows that during the year, the board subcommittees and service directors undertook a lot of work to refresh their risks during the year. So while the overall numbers are broadly the same, risks were closed and new risks were opened. I have made reference in the report to locally identified team level risks, and you'll probably notice that a lot of those are rated either high or significant. And I think it's important to note there that that rating does reflect the team's perception of the risk, which might not be in line with the trust perception of the risk, but it's the team that are experiencing the risk. A lot of them are due to safety issues. So I think it does feed back to Jane's point earlier on that people are comfortable using the risk register process to raise the concerns that they are worried about. And finally, the report just summarises a couple of things that have gone well during the year, including putting the risk register into the new format, developing the risk appetite statement, and the internal audit on risk maturity.
Thank you, Sue. Thank you for explaining the new format. As you say, certainly the number of risks on the BAF is slightly above what Grant Thornton recommended, but we're very close to it. But need to be mindful of making that much higher. On the number of significant risks, while I think about it, I never think it's a bad thing to have significant risks. I always think a risk register which doesn't have any, particularly at board level, is just looks strange, because most organisations are going to have at least one significant risk. But great report. Thank you so much for all the detailed analysis. Are there any questions? I am not seeing any at the moment. Thank you, Sue. And I know, of course, November, as you indicated earlier, will be a significant time for the board to completely go through the BAFs in more detail, the BAF work. Thank you. Okay. I'm conscious of time because we've got part 2 to go through as well. So we're now on to committee reports, board visits and Council of Governors update. So let us go on to the committee reports and very much focusing on any key points. So the first one we've got, Yemisi, is PQAC.
Thank you, Chair. I'm going to assume everybody has read the paper, and I'm happy to take any questions. Just to say, as usual in PQAC, we are focusing on all the quality areas, and specifically the ones that the board has particularly raised as issues for us to have greater oversight on. So again, we continue to monitor reducing restraints and all the work that's going on in the various sectors around that. We look at that data and we discuss any of the desktop reviews. Section 136, we're still monitoring that in detail. Obviously, at our last meeting, we discussed the HMP Wandsworth Recovery Plan that Ian had already talked about in his report, so we took that in great detail. We continue to look at SIs and the action plans and closing outstanding actions that have been there for a while. So we have made progress on that. As is our custom, we always have a presentation from one of the directorates, and we had an excellent presentation from CYP. They were able to tell us the challenges that they're facing, the mitigations that they've put in place, the successes that they have had, and it was good for us to be able to really understand what was going on the front line in that directorate. So that was really positive, and we gained a lot of assurance from it. Also, I just wanted to mention the Improving Lives programme. This is one that I'm sure many of you have heard of. It's a new thing that we've just introduced over the last couple of months, and the quality assurance team are doing great work in that sphere, and it's really allowing us to see what our issues and challenges are in specific teams, and almost doing our own kind of internal CQC audits or inspections, and then giving them support in order to improve in certain areas. I myself went on the district nursing one that we did a couple of weeks ago, which was absolutely fabulous. It was great to see the work that was being done there, and the amount of assurance that then goes back to the exec and subsequently to PQAC and the board. Yeah, that was really impressive. And the only other thing I wanted to mention was things like PFDs. We still continue to monitor those, the ones that we've got in, and we do thematic analysis with other trusts as well to see if there are emerging themes or learning from best practice. So those were the only areas that I was going to highlight, but I'm happy to take questions on anything else. Thank you.
Thank you very much, Yemisi. Any questions for Yemisi? Thank you. I'm not seeing any. Thank you again. On to QI and Innovation Committee. I know Amnan's not with us, but I think either Vicky or Iffy, you may wish to comment. No.
Not a great deal to comment on. If we assume that the papers have been read, I think we continue to receive feedback from teams about QI. And our priorities remain 2 or 3-fold. One, of course, is how do we make sure that good work that comes to us is actually shared across the organization and that we scale up successfully. And the second, which I know has been a running theme throughout our meeting this morning, is about how do we ensure that we truly co-produce with service users. This whole notion of small I, capital I, we want to do away with and then drive things forward. And just one last thing that I kind of want to say is that although at the QI committee we tend to think about projects, you will agree with me that many of the things we've talked about today, particularly Lauren's presentation, we've used QI methodology, and so that really pleases me no end. That 3 years down the line, we really are embracing this methodology, which is about those of us at this meeting not thinking we know it all, but really going to those for whom we provide services, as well as those who deliver services, and asking them to help us to find the right solutions. What I would then want to see is that the solutions we find are embedded and that they last. That's another area that I think we seem to struggle.
Thank you, Effie. And good to see 151 projects that are ongoing. So there's plenty of things being tackled there. And also, Effie, myself and Vicky have just exchanged some thoughts outside of the meeting about at what stage we'll be looking to see what benefit analysis can be made to show us the success of the projects. And Vicky has responded to say there's probably a few months off that, but towards the end of the year, I think she'll be providing something along those lines. Were there any questions for Iffy? I don't think there were, so thank you very much for that. Next on to the business committee. Well, in fact, Joe isn't here, I don't think. Correct me if I'm wrong. Sally, is that correct? I don't think we've got Joe with us today, have we? No. So yes. You agree with that?
Yes, Joe isn't here. Would you like me to very quickly highlight the key points in the report, Steve? I
think that would be an excellent idea. Thank you.
Right. So we'd had an increasing trend of surpluses month 1 to month 3, and though I'm going to assume that everybody's read the pack, you will see that that has been reversed in month 4. Specifically, that is because we have looked at the level of COVID spend that we've actually incurred versus the top-up monies that we were given. And it's broadly about a third lower than the top-up monies that we were given. And we took a decision that in order to make sure that we were able to hit our break-even plan at the end of each one, that we would return the unused element of the COVID monies. That is non-recurrent, and it's in line with the South East London ICS policy that we have now written and has been adopted around returns of funding. Just to remind the committee, all of the COVID top-up money was given to South East London ICS in totality, and then they took the decision collectively about where those monies would be dispersed. And what we've effectively done is said we don't need it in each one, and we're parking it for H2. We have not got the planning assumptions yet for H2, so we're still waiting for that guidance to come out. That's likely to come out sometime later on in September, but we're unlikely to actually complete the planning for that. Current timelines are October to November. So we will review and look through those elements at that period in time. We're fully expecting to meet our break-even position. We also shared at the last committee meeting the overarching ICS position. Now, those reporting tend to be about 2 months behind the internal reporting we've got at the trust. So at the time that we shared the month 4 trust financial position, we shared the month 2 South East London ICS position. Quick summary for the board is that all organisations were on track for delivering their H1 plans, and their forecasts were in line with that. We also covered off 3 contracts, one of which we're discussing in part 2 this afternoon because it meets the overarching board threshold in terms of approval. Those 3 are highlighted within the papers. I was going to leave it there and ask if there were any questions from members of the board.
Thank you, Azra. Do we have any questions? I'm not seeing any. So it's obviously very self-explanatory. Thank you very much. On to the partnership committee. Now, again, Joe's not with us. I think it's a very self-explanatory note. I've got nothing to add. Ithi or Azra or Andy, anyone wish to add anything? No? Thank you very much. Any questions from anybody? No. On to Suzanne, infrastructure.
Thank you, Chair. Very briefly, we had a discussion this morning about do we all know what each other is worried about? And I'm hoping that the cover sheet for the Infrastructure Committee is indicative of what worries me. But also, before I get on to that, I just wanted to draw attention to one of the items on the cover sheet, which I'm particularly pleased about, and it's that the estates have brought forward this 3-year programme of ligature management works. I wanted to just touch on this because I think it's really important that we understand that this isn't reactive ligature management work that's being done sort of in response to problems which are immediate and with us right now. This is a proactive programme looking at the estates to say what are the things that we need to do over the next 3 years to keep it as safe as possible, and to continually update our provision. And that's why I'm really pleased that this has come forward, because it is a proactive approach to ligature management, the sort of environmental risks of it. So the two things which worry me, I noted on the cover sheet, the ICS capital negotiations. Azra does a brilliant job on our behalf in terms of interacting with the other CFOs or directors of finance. I think our concern is that the governance processes in the ICS are perhaps not optimal at the moment in terms of approaching these questions about how to divide up too little capital between the providers. So there is ongoing work on this, and we agreed at the last Infrastructure Committee that ASRA would be able to round up a group of the NEDs from the committee to provide rapid advice if that were needed as this agenda develops. As I noted earlier, we're okay for the coming year. Our concerns are much more for the long term, which is why we've added an ageing estate risk to the Infrastructure Committee risks. And the other thing that I really wanted to draw to people's attention and emphasise its importance is the need for us to develop a green plan for the Trust. Some of you may have been aware that UCL declared a climate emergency recently. And since they did that, I've been trying to figure out what difference it makes if you declare a climate emergency. I thought, gosh, does this mean that the NHS will give us more money? I don't think it does. But I think the important point here is that this is one of the trickiest issues to deal with, because it's about a long-term investment for something that some people think may never happen, and if things do happen, we're still not quite clear what they might be. So I think we face a real challenge here, that the NHS is committed to achieving net zero carbon in a quite short time frame. There'll be some savings we can make, but we're also going to have to invest in order to accomplish that. And it means that we're going to have to be weighing priorities, for example, for sort of long-term investment for climate purposes against some shorter-term priorities around how we care for our patients. So there are some sort of tricky points along the line, and we will be having a discussion at the October Infrastructure Committee about the draft green plan, which Rachel T's team will be putting together. And then we need to sign off that plan in January of next year. So there's a lot of work involved with that and a lot to think about. And one of the issues which takes us back to the ICS is, at the moment, there's no mention in the ICS's discussion of capital funding, of the funding needed to help the NHS meet this target that it's set. But I think we could probably all agree, after the summer we've just had, that the climate emergency isn't one that we can just turn away from. We're going to have to face up to this and be courageous in what we decide to do and what we agree our priorities should be.
Thank you, Suzanne. And certainly, as you rightly say, in terms of the climate emergency and the capital negotiations through the ICS will be amongst the biggest challenges I think Oxleas has ever faced, because they're both very well. They're interlinked in some ways, but they are also of a huge scale. Do I have any questions for Suzanne? Do not. Thank you very much, Suzanne. On to Nina and the Workforce Committee.
Thanks, Stephen. I'm going to take a similar approach to colleagues and assume that the paper is read. I will just flag that one of the main areas for discussion at the Workforce Committee meeting that we rescheduled to last week was the RES and the DES that we've obviously heard from Rachel on already. The other topics that we discussed, and you have the report in your packs, is the medical revalidation. Agile working is the only thing that I would call out where a policy has already been put into place, and I just want to observe that this has been done in a really thoughtful way on a number of levels. We went through some very detailed documentation at last week's committee meeting on the policy and the supporting templates and some of the team charters that have been put in place. So just to reflect gratitude for the thoughtfulness of the approach that's been taken. Happy to answer questions.
Thank you, Nina. Very, very, very concise. Any questions for Nina? No. Thank you very much. Next one is me. Audit and Risk Assurance Report. So keeping with the theme, the papers have all been read. Couple of points to mention. First of all, on value for money from the external auditors, their report. No significant weaknesses. Believe it or not, that is quite complimentary. That's good. So that covers financial stability, sustainability, governance, and improving economy efficiency and effectiveness. And on all that, they found no major issues for us. Very interesting report about Leicester Hospital, University of Leicester Hospital, who made an adjustment to their accounts of 46 million and were the only trust body not to submit their accounts for Parliament in this year. So a very unusual set of circumstances. So the auditors posed us some questions which were answered by the Oxleas executive, and they raised questions about issues that had come out of that particular episode. If anyone's interested in it, it is quite an interesting read. So you can see it in the Audit and Risk papers, or Azra or myself or Sue Owen would be able to send you a copy. You'll also find attached to my report here, there's a full response to the annual report and recommendations from the external auditors. They were mostly agreed, but you'll see that Azra and the finance team have responded where, for any reason, we wish to do something slightly different. They were generally of a minor nature. For example, risks where Grant Thornton used an inherent risk factor, and we reworded that. But generally, that is good, and all the responses were very thorough and appropriate. And finally, just on the legal services, it's quite a lengthy report that we looked at within Audit and Risk. I think the one key thing I would mention to you, which is good, the premium we pay to NHS Resolution to settle claims, we paid in the this current year, we're paying £782,000, but NHS Resolution paid out on our behalf 1.3 million. So the key thing to take out of that is we paid a premium, but in fact we got far more benefit than the premium we paid. So it deals with that thing about, should we self-insure for ourselves, take the risk on ourselves? The answer is no. And also we have previously looked into the insurance market to see if we could get it insured elsewhere. But as you'll understand, no one wants to touch that because it's not a profitable business for them unless we paid a much bigger premium. So that was good to sort of see those figures, which we do every year. Happy to take any questions, but I don't think there are any. Thank you. Okay, we will move on to the Health and Safety Oversight Committee. Nina.
Thanks, Steve. This was the inaugural meeting of the Health and Safety Oversight Committee. And the first thing I want to say is I found it, as I think did others, incredibly helpful to have a space to be able to devote to health and safety, just that additional visibility, the kind of dedicated, the ability to have the dedicated discussions that I think the area reserves were hugely valuable. We focused on the Health and Safety Annual Report that draws on the results of the Eye Auditor, the full set of results now from the Eye Auditor system. It was an incredibly thoughtfully put together and comprehensive health and safety report, and I feel so much more assured now to be seeing the level of data that we are presented in the way that it is. It isn't just data. There are themes that are coming out that we now can explore and that the team is going to be taking forward. And those in particular, and the two that I want to draw out that we touched on for year 3 of the 5-year work plan for the health and safety strategy, is enhancing the quality of risk assessments and providing the necessary training at all levels to facilitate improved health and safety management. And we discussed, and we spent a fair amount of time discussing the results from the first full year of the Eye Auditor reviews. The overall trust score was 69%, but there was enormous variation across some areas. And as you would expect, the health and safety team is focusing over the next couple of months on re-auditing those areas that had particularly low scores and focusing in on the themes that emerged, one of which was, as we touched on already, the quality of risk assessments. We also focused on the internal audit proposal, which I think is particularly timely. So that is going to be looking at the design of the audit tools that we're relying on, as well as how we have seen them being operationalized to date. And I think the timeliness of that, of the results of that, will be particularly valued. We had a brilliant deep dive into the health and safety risks, the real risks that are posed from a health and safety perspective in prisons and forensics from Lawrence Mack, and it was sobering to see and hear some of the things that he presented, and it just makes it far more real for me, and I think for everyone around the table. So it feels as if that's going to be able to elevate the quality of the discussion that we're having around health and safety. One of the things that we will be doing, that I'm keen to do at our next meeting, which is in a couple of weeks, is to take a blank canvas approach to formulating our risks, focusing on the strategic risks. But I think that will be a particularly useful exercise in the middle of September when we reconvene. Happy to take questions.
Thank you very much, Nina. Do we have any questions for Nina? We do not. Thank you very much indeed. On to board visit reports. Obviously, we will take these as read, so I think it's just if anyone wants to draw attention to particularly significant items. Steve James, visit to various teams.
Yeah, I visited 5 HR teams, and I suppose the themes that came out of it were, I think they feel they can be used more with a bit of notice, so that I think they tend to be asked to do things for tomorrow when they know that the data was around before. There was a theme about using data better, and they argued that there was no reason why HR data can't be used in the same way as financial data is. So you could review things on a monthly basis and therefore reduce the number of surprises. And the last thing they said was, it's really important for people in senior positions to remember that change is an enormous amount of work for people like them. So executives can have bright ideas about restructuring, but it's an enormous amount of work to actually deliver it, and that mustn't be underestimated. Very interesting, very committed bunch of people.
Thank you, Steve. Throughout these board visits, by the way, unless I see someone raising their hand, I'll keep going through them if it's okay with everybody. So the next one is Scab Reward, which was myself, Iffy and Lorraine. I think the key things that struck me was because of a recent Cirrus incident, there was understandably, and we touched on this earlier today, just that sensitivity and morale issue sort of when you recover from a Cirrus incident. And you know, there are good aspects of learnings which take place. They also did mention a problem about recruitment for an overseas candidate. I think that was being dealt with elsewhere between Lorraine and Rachel, so I don't propose to go into that any more. I'm going to keep going on. Suzanne, corporate nursing.
I'll take the 2 visits together, actually, Steve.
Yeah.
So I've done 2 visits out of, I think there are 5 projected with different elements of the corporate nursing team. They've been, the 2 so far have been lovely in the sense it's given me an opportunity to come to understand some of the areas of activity within that corporate nursing team and to know the staff who are involved with them. I'm not going to say anything more about that because I've already commented on the visit to the infection prevention and control team, which you know, and called attention to how impressive their work has been. The only other thing I wanted to mention is that in both of these visits, some questions have been raised about our informatics provision, and those have already been followed up very rapidly with and by Alison. So I feel that the sort of actions which have come out of those visits have as I say, been followed up quickly and effectively.
Thank you, Suzanne. A question from Yemisi?
Well, it wasn't actually a question. It was that there was a paper, there was a visit paper before Scabbury. It was the forensic inpatient Burgess and Crofton that I did. Can you see it? That's page 406.
I beg your pardon. Yes, you absolutely did. I've just seen it on page, yes, page 406 of the bundle. I do apologise. Yes. Okay. Do you want to take that now? I don't know how I missed that.
It's okay. Yeah, just a really brief update. So it was the first visit that we had, myself and Matthew had done to forensics, and just to say how much the staff really appreciated seeing us face to face and coming to find out how they'd got on during COVID. So that was really positive. That was one of the main things that came out for me, and how delighted they were to show what they'd done during COVID, the changes that they'd made, and the improvements that they'd got out of it. So that was positive. There were a couple of issues that they mentioned, HR issues, but I believe those have now been dealt with. But generally, it was a really positive visit. Thanks.
Thank you, Yemisi. My apologies. On to page 413 then of the bundle, community mental health. That was again myself, Iffy, and Lorraine. Very good knowledge from this team, very aware of outcomes, which is always good to hear, to prove how the work that they do is bearing fruit. You'll see, we do ask this at every one of the branch visits, you know, are they aware of the freedom to speak up process and how to access it, and do they have confidence in the system? Very positive team with a very good team spirit. So Iffy and Lorraine, unless you put up your hand, nothing else from me on that. Okay, on to Greenwich Home Treatment Team, Jane and Nina.
Thanks, Steve. This was a very useful visit, as you would expect. The Greenwich Home Treatment Team have sorry, Suzanne's got her hand up. Was that on an earlier question? No. Okay. As you would expect, this team has a particularly broad brief and a particularly challenging one, given the pandemic. They were also, as you touched on about your visit, Steve, they were also knocked by some recent SIs, and that very much came across in the discussions that we had. They did have a particularly challenging experience, obviously, in respect of maintaining home visits over the course of the last 18 months. The issue that I want to focus on, you can see there's 6 that we noted down, but the issue in particular was around we're very good at looking after other people, but not very good at looking after ourselves. And there was an issue around reflective practice, and this was a common theme in the subsequent visit that I had with the ward managers, that we really need to focus on bringing this back and making the time and the space and the budget, if needs be, for it, understanding that it's not always easy to be able to recruit into the posts. But that really struck me. It was something that was a plea, and I would like us to be able to take it forward, and I know that attention is being given to it at the relevant levels. The other point that for me was an interesting one was just how the boundaries play out between Greenwich, Bexley and Bromley. And in terms of point number 1, there's an imbalance in terms of the numbers of patients that are discharged to bed and breakfasts in Greenwich, including from the other boroughs, and that therefore fall under the remit of the Greenwich Home Treatment Team. And this just struck me as an example of, we get told that we are more operational than strategic, but this is actually quite an impactful area that we need to look at. So I wonder if there is a cross-trust theme that we could explore there. Can I move on to the next visit if there's no questions on Greenwich Home Treatment?
Okay.
The next visit was a particularly sobering discussion, actually a very rich one, but a sobering one, with the ward managers of Avery, Shrewsbury, the Tarn, and the Modern Matron. Again, the issue of reflective practice and psychology and occupational therapy was brought up. That you'll see there as issue number 5. Also an important issue, and Joe always says we seem to land everything on the ward managers. This really came out in hearing some of the scale of the responsibilities that they have, and the work that we need to do, which I think is twofold. One, in terms of looking at the areas of responsibility for band 6 nurses, which is much more of a cultural change than anything else, was the impression that I got. And 2, in terms of, and I don't know what the answer is on here, but there were a number of issues a number of difficulties that were articulated around our ability to retain band 2 healthcare support workers, because these same individuals were able to qualify for band 3 posts with the benefit of an inner London weighting to their salaries, which is obviously quite a significant uplift. So I think there is more that we can and should be doing to try and resolve some of these workforce issues that probably go beyond just these particular wards. Happy to take questions.
Thank you, Nina. And certainly in view of those comments, perhaps something that Rachel Clare will wish to be involved in, I would have thought. But it's wide ranging, isn't it? What you're saying here, it cuts across a number of executive responsibilities. Okay. Thank you for that. Next 2 are for me. Bromley PCP. There were staff there, by the way. I know they're not showing up under attendees, but there definitely were. Very reflective team, very honest. Acknowledged their shortfalls, that there was room for improvement, but at the same time, were clearly fixed on making progress, and where they acknowledged that they'd fallen short, that there were things they could and should do about it. So it was quite a refreshing honesty, brutal honesty might be a better word from them. I'd like certainly one that we should go back to, I think, in the fairly near future, to see how they've improved. Iffy or Lorraine, I don't know if you want to add anything to that. I think probably not. Bromley Perinatal Service. I mean, the main thing here, great use of technology by them, great knowledge of their outcomes, again, knowing that they could prove that the service works. The sad and unfortunate thing is they've got 3 senior people who have either left, this is after our meeting in May, or are in the process of leaving. So it's a good, positive, loyal team, but will definitely be going through some very trying times as they either have a shortfall in recruiting people or just embedding new people into the system. So hopefully they will recover, but I suspect that will be rather difficult. There is a comment about poor Wi-Fi at the end there, but I know that's being taken on board and dealt with elsewhere. Suzanne Belmarsh.
Seems a long time ago that I went to Belmarsh. Sorry, I think Abby's got her hand up. Is that in the last visit?
Yeah, I just wanted to say that the perinatal have been able to recruit a new manager, and they've recruited a specialty doctor to Greenwich, and I'm supporting Shushma to recruit to the consultant positions, and we've got someone that we've got our eye on in Kent that we're trying to persuade to come over to Oxleas.
Oh, Abby, that's great news. I'm really pleased you said that, actually. Thank you. Thank you for saying that. Suzanne, back with you.
Yeah, so just very briefly on this, indicative of how long ago it was that it was a hot and sunny day. It feels like last year.
That's 1976, I think you're thinking.
It was a very worthwhile visit, because I think, as people would understand, some of the staff in the prisons can feel quite sort of cut off from what Neil referred to as the mothership. And I think that part of the benefit of that visit, is really indicating that those of us who are on the mothership are genuinely interested in the experience of our staff in prisons. I think the things which probably stood out are items which Lawrence is taking forward, and those are about the difficulty of recruiting staff in terms of competing with the private sector, and the greater flexibility they have around pay. The extension of the sort of BAFO awareness into prisons. It was quite interesting that when we visited one of the staff rooms, the computer was there with its home screen declaring, building a fairer Oxleas, and we said, so, what are your thoughts about this? And they said, what? What is it? So despite the fact it was there on the home screen, it wasn't something that it sort of impinged on their thinking. And it was a bit the same with the Guardian Service. I mean, it was interesting here in that although the Guardian Service had visited and the managers were aware of the Guardian Service visit, that those a bit sort of lower down the pecking order or the hierarchy weren't so aware of the Guardian Service and what they offered, which is in a way not entirely surprising but disappointing, because it's precisely those people who are at the bottom of the hierarchy that are probably going to need to know about the Guardian Service. So, as I say, Lawrence is picking up all three of those items, and I can see Rachel might want to say something about the Guardian.
Thanks, Suzanne. I just wanted to mention that clearly I think the way that we do things in prisons needs to be different to what we do to the rest of the organisation. We can't rely on the channels that we normally rely on, I think, to get things out there. And I'm increasingly of the view that we need a visit to each team basically every 6 weeks that just goes through all of the main things, reminds people of them, and that it's that face-to-face repeatedly getting the message out that's going to make the biggest difference. So that's the plan. It's not very new, it's pretty old school, but I think it's probably what we need in the circumstances.
Thank you, Rachel. Back with you, Suzanne.
I think I've already spoken to this one. Infection prevention and control team.
Absolutely, yeah. Thank you very much. Okay, Council of Governors update. I don't know if Andy wanted to say something on this, or Sally, you did.
It's all there. I think if there's any questions for me or Sally, otherwise just take it as read, I think. Thank you, Stephen.
Okay. I'm not seeing any questions. Thank you. Andy, so we're at any other business. I realise part 2, we need to discuss how we want to deal with that. But do you want to come back in here now?
Yes, please. Firstly, thank you to you, Stephen. Excellent chairing. So well done, and thank you in those circumstances. Big thanks to the staff networks. Good to see you here, and for your inputs to the work that's been going on so far. And to our governors for, again, really good questions pursued. Again, repeat my thanks to Richard and you know, and for everything you've done as a lead governor. You know, it's been an enormously comprehensive meeting today, which we'll need to reflect upon. But I'm also very thankful for my fellow Neds getting out and about. You know, they think face-to-face does matter. You know, I've managed a few face-to-face to individual teams, and there's always something you see that you never see when you're doing it on Teams. I want to mention just one visit, which is the Greenwich Speech and Language Summer School. If you ever have a chance to go and visit these summer schools, please do it. They are just fabulous. They really are, both for junior and senior. They get advertised every year. If there's any chance of getting out there, go and see them. It's actually a heartwarming experience to go and do to see them in action. Unless there's anything from anybody else, I think we're on the same feed for this, Sally, I think. But I want to say thank you to you all. Bring this part 1 to a close. And then if we have a, shall we do a 10-minute break? Would that suit people? Come back on this link at 14:20.